offers us an opportunity to reduce the potential harmful interactions between the criminal justice system and those who are suffering from mental health disorders, as well as improve the interactions that do occur by using the strategic framework to identify and invest in programs and services that have the best chance of making a difference. Today's program brings together experts from both criminal justice and the mental health communities to explore how we can use this framework to create better outcomes for the people that we serve. Our goal is to learn more about the model and the uses and best practices and explore current resources, gaps in services, and opportunities for government, as well as identify potential legislative, policy, and financial strategies that ultimately can increase the collaboration between the behavioral health system and our criminal justice systems. We're working and hoping for long-term solutions. I also would like to take a brief moment to announce the expansion of the Law Enforcement Assistant Diversion Program, or LEAD. The program is adding 2 additional jurisdictions, Carroll and Harford County. LEAD empowers law enforcement officers to refer individuals who may have a mental health issue or substance disorder crisis to public health services instead of making an arrest. It reduces costs related to the criminal justice system, improves public safety, as well as individual outcomes. A recent study by the University of Washington Harborview Medical Center found that the model results in a 58% reduction in recidivism and increased likelihoods that diverted individuals are able to obtain housing, employment, and see increased income. Currently, there are 9 LEAD locations in Maryland, in addition to Harford and Carroll, but that include Baltimore City and Washington County have active programs currently, while Anne Arundel, Howard, St. Mary's, Wicomico, and Worcester County are in the planning stages with the goal of launching their program in 2021. At this time, I'd just like to thank all the attendees for joining us for this very important program, this very important work. You all are on the front lines of these issues. You understand the challenges that people face and where improvement needs to be made. We are very grateful to be able to bring together so many different stakeholders across different disciplines to look at things from every angle and bring together the best ideas. With that, I wish to say thank you again, best of luck. Look forward to seeing the work that comes out of today's events as well as tomorrow's events. And with that, I'd like to turn it over to Judge John Morrissey, the Chief Judge of the District Court.
Thank you, Lieutenant Governor and Senator Hester. Good morning, everyone. My name is John Morrissey, and I'm the Chief Judge of the District Court of Maryland. It's my distinct pleasure to give remarks at this first of a kind for Maryland Sequential Intercept Model Summit. As those that work with me know, I love a good summit because of all the educational reasons and the opportunity to really share ideas with all of your colleagues from different groups. They are typically a great success, and I would expect that from this summit here today. I'm a true believer, a large supporter, if you would, of the mental health problem-solving court model, as it's, in my opinion, a recognition by the judiciaries across the country. And you know that us judges are really not the type that move very quickly to change anything, that a more holistic approach that matches needs of an individual to services, employment, training, housing, and transportation is really the best means we have to bring about lasting change. The Maryland judiciary currently has 7 mental health courts, 33 drug courts, 2 reentry courts, 8 truancy reduction courts, 7 veterans courts, and 1 back on track program. Statewide in fiscal year 2020, we accomplished 3,499 individuals participating in Maryland's problem-solving courts programs. It drives me crazy that we couldn't have gotten to 3,500. I wanted to round up, but they wouldn't let me. These problem-solving courts provide a clear path to success for its graduates. Recently, I handled an afternoon bail review docket in Prince George's County, which is my home county. In a docket of about 20 individuals, several had what I would consider to be potential mental health issues. Several more had substance use issues. Some had both. Fortunately, the Prince George's County District Court has both longstanding mental health and drug courts. In making the bail review determination, I think everyone can agree that the more options a judge has at his or her disposal, the better the outcome will be for the individual. For example, rather than preventively detaining an individual, I had the ability to refer them to the mental health court the very next Tuesday, where a doctor is available, and the mental health court judge will conduct a more needs-based analysis while still considering the safety of the community. Excuse me. The same is true of the drug court model. Sorry about that, folks. The intersection of our problem-solving courts and the sequential intercept model is very promising, but it takes a whole village to achieve success. It takes all of our justice partners, from court commissioners to our problem-solving court coordinators, our courtroom clerks, bailiffs, the Office of the Public Defender, the state's attorney's office, the local and state departments of health and corrections, parole and probation, the sheriff's department, and law enforcement can all benefit by a deeper understanding of the SIM model and how we can work together to ensure better outcomes for those in much need. I commend the planners of this summit, including leadership led by Senator Hester and Lieutenant Governor, and I hope that all of our attendees benefit with a greater understanding of any gaps that we may have, the opportunities that we can use to work together, and best practices that we can share among ourselves. I'd like to take a brief moment to thank all of our problem-solving staff and judges. They're on the front lines. They are wildly passionate about these issues and show resolve day in and day out to improve our justice system, which is why I will now turn this over to Judge Nicole Taylor, the presiding judge for the drug court in Baltimore City, and she will share her experience in developing a pilot location for the SIM model. Thank you, everyone. I'm glad that so many people are attending this. I love the participation from so many people, and I hope you all remain safe and healthy. With that, I'll turn it over to Judge Taylor.
Morning, everyone. Thank you, Judge Morrissey. Thank you, Senator Hester, Lieutenant Governor Rutherford, and all the other lawmakers and partners that are participating here today in the State Summit on Behavioral Health and the Justice System. I'm looking at the list of participants, and it's delightful that I recognize, maybe more than half of you. It's great to have everyone join in. Today's summit on the sequential intercept model is very timely. We have justice stakeholders from all three branches of government that are doing amazing work in their own sphere of influence. And we have providers who are dedicated to improving lives through mental health and pro-social behavioral treatment. The SIM model brings us all together to try to create a seamless and effective method of better caring for our citizens with behavioral issues that become justice involved. It allows us to recognize not only the situation right in front of us, but what came before that and what will come after. It helps avoid duplicity, and it speeds the timely implementation of services. Judge Morrissey mentioned my pilot program in Baltimore City, which I will talk about in a moment, but first let me tell you about my program that's actually working. That's a tease for my not working pilot. I currently preside over the drug treatment court in Baltimore City. The court was founded in 1994. It was the first problem-solving court in Maryland. It's a comprehensive court-supervised and voluntary treatment-based program for substance users charged with misdemeanor and concurrent jurisdiction felonies in the district court. So the mission is to serve the community and increase public safety by integrating a coordinated treatment response for those with substance use disorders, many of whom also have co-occurring mental health disorders. Last year, it was its 25th year, and we restructured the program to better fit with the National Association of Drug Court Professionals' best practices model. And we also wanted to restructure it to better serve the city, which, like most of the country, is experiencing the opioid epidemic. In restructuring, it was important for us not only to recognize the changes in the law and the criminal justice system, such as the Justice Reinvestment Act, but we also had to recognize the changes in the treatment community, such as the 180 on medication-assisted treatment that most providers have taken. And of course, we support medication-assisted treatment in our court. It was also really important to look around the state and see what was going on in my own backyard. And as much as Judge Morrissey likes a good summit, I enjoyed a good meeting. I was very fortunate to attend a meeting with Secretary Green on the planned project to create a therapeutic environment for those that are incarcerated pretrial in Baltimore City. I was able to hear Steve Shue speak about the ODMAP project, which is phenomenal, and you're lucky to have him as a speaker. I get the Baltimore City overdose emails daily. I've met with Martha Danner and other members of DPSCS. I've met with providers, health commissioners from multiple jurisdictions, members of police agencies from multiple jurisdictions, and Lieutenant Governor Rutherford mentioned the LEAD model, talking about that, seeing what crisis response people have going on, like Anne Arundel counties is amazing. I also met with many, of course, courts, different members of the judiciary and problem-solving courts around Maryland. So our team was able to come up with a whole new playbook after 25 years, a whole new playbook for what our problem-solving court one is going to look like and what it has looked like over the past year. And that playbook would not have even be recognized as a drug court in 1994. I tell you all that background because in order for the SIM model to work, you need to look outside your own toolbox. You need, of course, to have policies and planning and re-entry plans and resources. But really, for the SIM model to work, you need communication and collaboration. And everyone that's in the summit has a vested interest at the intersection of public safety and public health. Different agencies and disciplines and levels and branches of government are doing extraordinary things right now. But what if you don't know about them? What if you don't know about the ODMAP model? What if you don't know about the LEAD program? What if you're not sure what Anne Arundel County is doing in terms of crisis diversion? We have to communicate with each other. We have to agree to a policy and then stick with the plan, communicate it, and continue it. We need to use the resources that we have for recovery and reentry in an efficient and streamlined way. If you think I basically just said the same thing 2 times, well, I want to thank you first for paying attention, but also I said it twice because it needs to be said twice. For the SIM model to work, we need to listen to all our partners, learn, and then have that follow through. In listening, we can adapt. We can identify our strengths and weaknesses by looking globally at how we're advancing public health and public safety. We can identify the gaps in our success and lean on our partners for identifying solutions. We also need to find a common language to communicate. That language, folks, even for those who don't want to hear it, is data. With effective data collection, we can create a collaborative and diverse model. You're looking for a SIM model that has a strategy of participation for each agency and discipline. And when you rely on the data that you're collecting to see what's working, that's what comes together into a plan. I'm going to circle back to my pilot program that Judge Morrissey mentioned. When we were restructuring the drug court, we wanted to create a mini SIM model right in the Baltimore City District Court. We examined all our data and realized that there was a big gap between arrest and then the first court appearance. So it was usually 30 days in jail or 30 days released to the street. So we put together a pilot program called the Critical Time Intervention. When dealing with opioid users, an arrest is a critical time. And this is really often true for those with mental health issues as well. If we could just assess the need and the willingness for treatment and triage your cases so that the first court contact was within days of an arrest, we realized we could take those 30 days of jail time or 30 days of just on the street time and turn them into 30 days of treatment before a criminal case was even heard. So as a defendant, the model didn't have you losing any of your constitutional rights. You didn't waive any appearances or defenses. You just got matched with treatment. That's the critical time right after arrest. We got you matched with treatment. We had a really amazing buy-in from the DPSCS pretrial services. We discussed and planned with all the other agencies that would make it all possible. And even in-house within the judiciary, we had to develop a new case type and for our court clerks and for our commissioners to identify these cases. We even had a flow chart. I love this flow chart because that's the only thing that's still working out of my program. We didn't invent the idea. We modeled it on the really successful opioid courts in New York State and some other states. But after all that work, we had one stakeholder who pulled out. I'm not pointing fingers, at least not today, because this is being recorded, but it shows the importance of that commitment and that continuity. It also shows the importance when you're developing a SIM model of having memorandums of understanding to work together, even if it's just for a defined period of time. So this summit is not the first step. The first step has already been taken by each and every one of you. Your work on your end is what we need to know about to make the SIM model work. Now, I haven't given up my CTI court pilot project. I may have been a bit delayed by a global pandemic and some other politics, but I'm going to keep pushing. And I applaud all of you for your willingness to become closely involved with the difficult task of creating and implementing a SIM model. I feel like, at the amusement park when you said I rode the Super Duper Looper and all I got was this t-shirt, I feel like, I created a pilot program and all I got was this flow chart. I'm going to end with a quote from John F. Kennedy, which I think is really what this summit is about. The quote is, "Partnership is not a posture, but a process." Thank you very much, everyone, and enjoy the summit. You're really in for a treat. Thank you for having me. I'm going to throw it back to Senator Hester.
Thank you so much, Judge Taylor, Judge Morrissey, and Lieutenant Governor. As was mentioned earlier, the State Summit is a key deliverable of our Commission's work, and it's a joint effort between our Subcommittee on Public Safety and the Justice System, which I chair along with Dr. Linda Mineski, and the Subcommittee on Crisis Services, which is chaired by Steve Hsu, and the Crisis Service Subcommittee. And I'd be remiss without thanking Mr. Hsu and Mr. Hsu's office, in particular, Marianne Gibson, who has done a tremendous amount of work to get us off today and towards this excellent two-day focus. Over the next 2 half days, we're going to focus both on what's working well in Maryland and where we can improve. And I believe that we've assembled the right team of people to do that, with over 200 experts joining us on the call today. But we do have a huge challenge in front of us. As we look at what's working, where the gaps are, I wanted to share a few statistics. Approximately 2 million times a year across the United States, somebody with severe mental illness finds themselves admitted to a jail. That's 2 million times a year. And according to the Maryland Alliance for Justice Reform, at least 39% of our local jail inmates in Maryland have a mental health disorder, which is astounding. For many of these individuals, the statistics show that their prison stays will likely be longer, and that of the average incarcerated person, they'll be longer than the average incarcerated person, and they're more likely, unfortunately, to return to the criminal justice system. So our work is certainly cut out for us. I think it's also extremely important to highlight that for our Black and Brown community members, these concerns are not only compounded by pre-existing racial disparities within the criminal justice and healthcare systems. Our recent report found that 70% of Maryland's prison population was Black in 2018, compared with 31% of the state population. And that rate far surpasses the next closest states of Mississippi, South Carolina, and Georgia. We cannot and we will not ignore or forget the unique challenges Black Americans with mental and behavioral health illnesses face, in particular within the context of our criminal justice system. Now, we don't want to get lost in what's going wrong. I lose hope that problems these big can't be fixed, because I really believe that they can. Today, we're going to highlight what's going right and build on the incredible work of what's happening here in our own backyard. Systematic problems require systematic solutions, and the most effective way to address this problem is with an array of experts, every single stakeholder at today's table, who can use their experience to craft solutions that include all of the intercepts between criminal justice and mental and behavioral health. And today, I'm really honored to have the opportunity to address this with you all at the table. Over the course of the next several hours, we will highlight current efforts in our state to address the mental and behavioral health needs of our communities, starting at Intercept 0 and going all the way to Intercept 5, which you'll learn more about shortly. Then, tomorrow, we'll hold smaller work groups that will begin forming recommendations for how we can proactively and systematically address the mental and behavioral health needs of Marylanders before, during, and after their interactions with the justice system. We have an incredible lineup of speakers, and I'm sure that with each panel, all of you will have plenty to think about and plenty of questions to ask. As a non-expert in the room, I'm excited to see what everybody comes up with. I'm excited to learn about your work and to find new ways to tackle problems we have struggled with for decades. And I'm especially excited to see the type of positive impact that we will all have once the summit is over. This is important work. What you do matters so much to your communities, and I know that you all are excited too. I wanted to say one final thank you before I turn it over. The Commission is especially grateful to the SAMHSA Gain Center, who has provided the technical support through Policy Research Associates. PRA is a consultancy focused on creating positive social change for people and communities through technical assistance, research, and training. And they are the ones delivering the summit. And I might add that it's the first time they've done it virtually. As part of their support, they will also deliver a summary report of this summit, sketching out the best practices, gaps, and recommendations for the state of Maryland. So without further delay, I'd like to turn it over to Dan Abreu, Senior Policy Associate with SAMHSA Gain Center, who will be leading us through the summit. They've conducted these state summits over 10 plus many states, but this is the first time virtually. So we're all going to learn together. Thank you so much. Over to you, Dan.
Thank you, Senator. And it's a pleasure to be working with the state of Maryland and with the officials here today. I really want to thank Lieutenant Governor Rutherford, Justice Morrissey, Judge Taylor, Senator Hester for their opening comments, because they were right on. I mean, very targeted in their expectations, I think, for the summit, and we hope we can fulfill them. And actually, this is really a process that will take place, among all the participants. That as a group, we will be working to fulfill those expectations by our participation and our expertise. So, certainly the collaboration was a common theme in the comments that were made. And also, I thought the comments about it's important to inform the community about what else is going on in the state. Indeed, the summit is structured like that. We've highlighted a couple of the really good programs in your state, excellent programs that can, again, where your communities can share with each other what's going on. And I think that's an important outcome very often with these summits, that there's an opportunity for cross-county learning, cross-city learning that can also inform the state on their initiatives. And then the other thing is data. There's been so many advances now around integrating data between the justice system and the health system that will improve outcomes both on the health side and the justice side. So I think that your comments were very relevant to the work that we're going to undertake today. A little bit about my background. I've been with policy research for 15 years. Now, this was my retirement job. I originally told Hank Stedman, who was the director of policy research before his retirement, that I would work for him for about 3 years. But the work's just too challenging and too interesting to leave. I'm here with, and before policy research, I oversaw reentry for New York State prisons, people with mental illness coming out of New York State prisons, and worked very closely with parole and a number of community agencies developing programs statewide. I'm presenting here with Dr. Deborah Pinels, who's a national expert across the justice mental health spectrum. And at this point, I'd like to ask Dr. Pinels to introduce herself.
Hello, and good morning, everyone. Can you hear me and see me?
Yes, you're good.
Oh, good, because I can only see you, Dan. So which is always a pleasure. It's a pleasure to be here today, and I really want to thank the leadership in Maryland for putting this summit together and inviting me to participate in this great day. I can tell you, I have participated in your shoes in 2 different states, in Massachusetts, where I ran forensic services for 8 years and worked on a state summit, as well as in Michigan, where we had a state, where I currently am the medical director for behavioral health and forensic programs and a clinical professor of psychiatry at the University of Michigan. And in my experience, the state summits are real opportunities as catalysts for moving forward. There's a lot of momentum that I have seen across the country in my work with the Gain Center as a senior consultant, there's certainly a lot of positive momentum in the behavioral health and justice space. I think a lot more people are interested in the topic, and a lot more people are willing to look at how to be change agents to make sure that people are routed into the right doors at the right time for the right reason. And these state summits really give an opportunity for people to get together, get inspired, and to really get their wheels turning about what could be done in their jurisdiction. So that's my background. I'm a psychiatrist and with addiction medicine and forensic psychiatry certification. I've been working in this space for many, many years, and I'm delighted to be here with all of you.
Thank you, Dr. Pinal. So advancing the slides. There we go. So the major themes that really are going to underscore a lot of the work that we do today are because there's been so much national focus now on the police crisis intersection. And so part of what we'll be looking at, will be underscoring our work, will be the transition or expansion from police-led crisis response to provider-based response and increased law enforcement support and increased support for law enforcement. Due to COVID, there's been a reduction of arrests and a reduction of incarceration. So there's a real question about what return to normal will look like. Some of these changes are certainly positive. And so, states around the country are re-examining some of their policies. Bail was mentioned in the opening comments, and a number of states are looking at bail reform. COVID, to some sense, to some extent, has hijacked that policy, those changes in policies, because of the people aren't as frequently being incarcerated. There's more use of desk appearance tickets and citations. There's been a reduction in jail census in both the health and the justice areas. There's been an expansion of telehealth. And preliminarily, both the health system and the justice systems are reporting benefits from that. So again, that's another thing that we'll want to be looking at moving forward as we come out of the pandemic, and being very hopeful there. And of course, there's a renewed focus on diversity, equity, and inclusion in the justice system, and there's much more urgency in addressing that, both on the criminal justice side and the healthcare side. And the opioid response is an ever-present scourge in many communities. Again, many communities are reporting an increase in opioid overdose as a result of COVID. So those will be some of the major things. Population characteristics. So we know that there's almost 2.1 million people incarcerated. This is from 2018 data from the Bureau of Justice Statistics. And over and a total of over almost 7 million people under correctional supervision. Probation has the greatest proportion of that group under correctional supervision. Almost 2/3 of the group under correctional supervision are under probation supervision. So probation are huge partners in working with the health system for people with mental health and co-occurring disorders. And then there's the issue of the jails. While there's, jails generally have smaller populations than prisons, there are 19 times more admissions to our nation's jails than to the federal prisons. So there's a real churning that goes on there, and it can be very challenging to engage people in the early stages of the justice system. But as Judge Taylor pointed out, there are strategies to do that. Next slide. So we know that there are racial and ethnic disparities across the intercepts, with impaired healthcare access in intercept 0, higher arrest rates, and disparities in referral and participation in diversion programs, and also in bail and pretrial release decisions and probation revocations. So across the criminal justice system, when we're doing our work and planning, we need to address these causes of these disparities, and more importantly, address specific strategies to address them. So we know that, let's see, I'm having a little trouble with the slide events. Go back one slide, please. Okay, thank you. So in the
Dan, I think you froze up.
Deborah or Matt, I wonder if either of you could finish up Dan's slides while he's trying to get back in.
Yeah, that's what I was just texting you. Read my mind. That's what I was just texting Matt to see if that would work. But I will just jump in and do that since we have the pause.
Thank you so much.
I'm sorry, I'm back. I'm back.
I knew that would be the secret as soon as we went to rescue you. All right.
Yeah, my computer froze. I apologize for that.
Okay, keep going then, Dan.
So the BAB, do I have control of my slides or do you? So is that a right click, or I'm having trouble moving the slides? There you go. Okay, so yeah. Okay, so in the interest of time, and I apologize for this, but so we also know that there are high rates of substance use in both the jail and prison population. But what's often not underscored or overlooked is the prevalence of trauma in this population. This data comes from a cohort of 13 programs that participated in SAMHSA-funded jail diversion programs. And there was an evaluation component which did a trauma inventory for the participants in the program. And what we found, looking at the data, is that both the women had a lifetime prevalence of physical or sexual abuse of 96%, and men had an equally high prevalence of lifetime trauma, 89%. I mean, very often it can be assumed that women have higher prevalence rates, and in the community that may be true, but certainly when you're talking about the justice system, there are very similar rates of trauma between men and women. The data that really surprised us, though, when we looked at current trauma, which was defined as having had a traumatic episode the year before the arrest that got them into the diversion program, current trauma for women was 74% prevalence. And for men, it was higher even, 86%. Now, the types of trauma were different between men and women. For women, it tended to be more relational trauma. And for men, the trauma tended to be more street violence that they were exposed to, either vicariously or through having been assaulted themselves. So, and then, so we've talked about mental health, we've talked about substance use, and we've talked about trauma as health factors, but there are also very high rates of medical, comorbid medical conditions with this population. They have higher rates of hypertension, diabetes, cardiovascular disease, as well as infectious disease. And this study highlights really the fragmentation of the healthcare system and the justice system and the healthcare system in the community. The researchers here looked at 100,000 releases of Medicare recipients from correctional facilities and compared them to the general population for 8 years. And the individuals coming out of the correctional system were 2.5 more times more likely to be hospitalized within 7 days of release, and twice as likely to be hospitalized within 90 days of release. And more tragically, within 30 days, the mortality rate for individuals being released was twice as high as the general population. So in summary, how are justice-involved persons different? They are more likely to be homeless, more likely to have co-occurring disorders, use a greater variety of services at a higher cost. While incarcerated, they're more likely to have disciplinary problems and be unemployed, and they have more psychological impairment and tend to have longer lengths of stay in jail and prison. So I want to talk more about the healthcare systems of the community healthcare system and the justice healthcare system. And it seems to me, after years working in this field, that what we have is a corpus callosum problem. The corpus callosum is a structure that allows communication between the two hemispheres of the brains. It's responsible for transmitting neural messages between both the right and left hemispheres. The primary function of the corpus callosum is to integrate motor sensory cognitive performances between the cerebral cortex on one side and the brain on the same region on the other side. Unfortunately, when it comes to healthcare integration between behavioral health and criminal justice system, there is a stunning lack of integration. Historically, planning, funding, program development in the two systems has taken place in a parallel rather than an integrated fashion, resulting in barriers to healthcare, gaps in services, and inefficient use of resources. For example, while conducting a SIM mapping exercise in one community, participants noted that the police did not use a crisis stabilization center. Police reported that it was located outside their jurisdiction, so they rarely used it. Had the police been involved in the beginning in the planning of the crisis center, jurisdictional issues could have been worked out or possibly another site proposed. In another community, the community healthcare system was implementing an electronic health record and a health information exchange, allowing the providers in the community to share real-time healthcare information about participants in their programs. At the same time, the jail was also implementing an electronic health record, separate vendors, of course, and an opportunity was missed for integration. What would a system look like that included justice-involved persons, a health system look like? What structures for communication planning would integrate healthcare planning for justice-involved individuals and prevent barriers to care? So these are some of the things that not only will we be looking at diversion opportunities as we go through the next 2 days, we want to really be examining how our healthcare systems can be better integrated. So many of you are familiar with the Sequential Intercept Model already. We've done the sequential intercept mapping in Cecil County. We've done it in Calvert County, and also in the 5 Eastern Shore counties within the past. Cecil County was actually within the past week. So I know many of you are familiar with the model, and I think Secretary Green, if I'm not wrong, actually went to the first Gaines conference back in 2000. But again, it was developed by Dr. Patty Griffin and Dr. Mark Munitz as a way to better understand how people move through the justice system and to better ensure prompt access to treatment, opportunities for diversion, timely movement through the justice system, and most importantly, engagement in community resources. In many communities that we work with, different systems have different perspectives. And it's a little bit like the moral of the blind man and the elephant. If you're feeling the front part of the elephant, it might be described as a snake. If you're feeling the leg, it might be described more as a tree trunk. Similarly, if you're working in law enforcement and dropping people off at the emergency room only to see them back on the streets before the end of the shift, you presume the emergency crisis system is broken. Or the booking officer at the jail booking the same person for the third time this month, you presume the court system is broken. Or if you're working in the emergency room and people keep coming in released from the jail only days before for emergency population, you'll assume that the jail isn't providing appropriate follow-up. So communities have lacked a way to take a step back and look at their whole criminal justice and behavioral health system and really see how interdependent these systems are. So the sequential intercept model helps with taking that broader look and seeing how to better design your program so that it is seamless. So at this point, I think I turn it back over to you, Deb, and I'll be glad to, Dr. Pinels, and be glad to advance your slides for you.
Great. Fantastic. All right. So I'm going to walk us through the sequential intercept model just for some level setting. And even if you've heard of it, I think it's good to rehear about it and to think about what it means for your own systems as we think about where we can identify those gaps that Dan described, and then come up with strategies to address them. And that's what we're going to be spending tomorrow, actually doing some exercises related to that. So let me start with intercept 0. Now, the sequential intercept model initially started with intercept 1, which was that first police encounter, as we were looking at ways to divert people from the criminal justice system. But after many years of working with the SIM model, intercept 0 was introduced formally in 2017 because everyone starts with, well, why are the police even getting called? Couldn't there be a better system that would avoid law enforcement altogether, or avoid law enforcement in the sense of arrest altogether? And so intercept 0 was sort of born out of those concepts, where the idea of crisis lines, the crisis care as an entire continuum, including where hospitals fit in, really needed to be discussed and fleshed out for each community. And this is, I would say right now, is the kind of the hottest time I've seen for intercept 0 conversation along a lot of different dimensions. We can go to the next slide. So, for example, there is a lot to be said about what this means. A crisis response is, if you back it up, it's a whole bunch of different things. It can even mean pre-crisis response, like in Michigan, where we have a Pure Warm line that's set up for people to call just to talk pre-crisis. But then you can look at the mobile crisis outreach response, models where police are co-responding, the idea that there's urgent care like we have for physical health conditions, but you could have for behavioral health conditions, emergency room diversion opportunities so that not everyone with an emotional crisis needs to show up in the emergency room. That might include work with peer support and navigators to help people get routed into access to care that's not definitively the hospital as the only place to go. Crisis stabilization units, which are usually smaller facilities with a short length of stay, They may include voluntary or involuntary services depending on how the state designs them. Crisis residential, which allow for somebody to kind of re-stabilize from a crisis for a bit longer. Crisis respite, again, allowing people just some time out, if you will, from what's going on in their lives and some of the strains. Transitional residential, peer respite residential, and even critical time intervention, which can be a kind of almost a wraparound support model that provides intensive intervention at the time of a transition, all the way to warm handoff to more stability. And, so there's an entire crisis continuum, and a lot of states are looking at this with their Medicaid systems, with their behavioral health systems, at the local level, at the county level, and at the state level to examine what could be built out in that continuum. And that's all Intercept Zero. We can go to the next slide. For example, we see Texas did an entire crisis service redesign. The state of Washington introduced Senate Bill 5533, which was decriminalizing misdemeanors for persons with mental illness, and it allowed for a 1% sales tax for the establishment of crisis stabilization units. In North Carolina, the Mental Health Department Emergency Department Length of Stay Action Plan looked at how to reduce the waiting periods for people who did show up in emergency departments. And then finally in Denver, there was the City of Denver Social Impact Bond, which supported housing focused on frequent user systems engagement, the FUSE model for a targeted population. I can tell you in my own state of Michigan and in my own county, after a sequential intercept mapping workshop, there was a lot of interest in passing a millage, and the community passed a millage which allows for additional funding that's shared between public safety and behavioral health, and is working on crisis stabilization and Intercept Zero types of responses. Next slide. In California, just some other examples, the Investment in Mental Health Wellness Act developed urgent care centers, crisis residential programs, and mobile crisis supports. We saw Virginia institute more crisis intervention team assessment sites. And in Arkansas, there's a $14 million budget initiative to look at crisis stabilization across the board. Next slide. In Maryland, you have your own activities going on, very much in the forefront, and a lot of conversations I'm in talk about what's happening in Maryland as another leading state that's looking at this crisis care continuum. And you can see here from the map how the Behavioral Health Administration has been committed to ensuring that individuals in crisis have access to immediate and appropriate care. Now, there's more to be said about this, but it includes mobile crisis teams, walk-in centers, and even what's called the safe stations, which allow people to have an intervention early on in the crisis to avert potential justice involvement and to access improved care and services. And these are usually going to be looked at for people with both mental health conditions as well as substance use disorders, or a broader spectrum of mental conditions as well, sometimes even for people with intellectual and developmental disabilities, with or without co-occurring mental health conditions who show up in crisis as well. Next slide. There's also this initiative that people are talking a lot about, which is the Certified Community Behavioral Health Clinic. And there's different ways that this has come about. This has been a federal partnership that's allowed for demonstration programs. And the CCBHC model really looks in some ways similar to the FQHC model, the Federally Qualified Health Centers, in terms of what it allows for funding of services, but it requires several prevention strategies that one could describe as an Intercept Zero kind of opportunity, which include funding for bridge medications for people moving from one system to another who need prescriptions filled, reach-in services, connectivity with justice agencies to promote diversion, day of release access, so same day access to services so they don't have to wait for appointments, and then the monitoring through quality measures that include reduction in jail admissions potentially. And so these CCBHC demonstration projects are really important for us to look at across the country. Next slide. In Maryland, you were one of the identified states for CCBHCs. And there's a few of them highlighted here that have looked at this as a demonstration initiative to look at these interventions that include Intercept Zero opportunities for crisis services as well as same-day access. Next slide. Then we shift from Intercept Zero into Intercept One and where the police may get involved. And that is, and you can see, the color scheme in the depiction of the Intercept models it's kind of shades because it really does not have a bright line distinction always. And we move into 911, dispatch, local law enforcement. Clearly, this is a topic of conversation these days with what's going on in terms of social justice and thinking about responses and who might be best to respond to what situations. You can go to the next slide. And this raises this whole question of what is our role of our law enforcement today? Now, with the whole conversation of an emergency crisis line, the number 988 being approved by the FCC as the transition to the National Suicide Prevention Lifeline, and perhaps serving more than what 911, perhaps serving a different set of issues than 911 serves. The question is going to be, when do police get involved and what are the police roles? So in all jurisdictions in the United States, and I would say elsewhere in the world, law enforcement has two functions. One is its police powers to keep the community safe and govern the laws in our society to help us make sure we're all law-abiding citizens. But it's also got this function of parens patriae, which is the government acting as parent and helping to serve people who may not be able to support themselves in a safe manner. And so law enforcement plays an important role and they're granted certain powers. So even in a world where more is shifted for, let's say, clinicians or social service agencies to respond to certain crises, there will likely be an interface that continues with law enforcement. And we need to really be smart about how that gets developed further, how we look at issues of the helping train the police, helping them understand where what their function is, and then also helping recognize the challenges that police have and the traumas that they may encounter in doing the work that they are set out to do. So trying to build these systems in a more intentional way that does look at race and equity in that lens, but also looks at building our best service providers who function in multiple capacities. Next slide. So there's a number of specialized first responder models that are out there. The crisis intervention team model, which really is training police, a section of the police force to be better at dealing with behavioral health emergencies. That's where the origination of the CIT model came in. There's been lots of conversations about the CIT model and that it's really more than just a training, but that is a specialized first responder approach. The co-responder models, which include law enforcement assisted diversion, the Pima County Mental Health Investigative Support Team, on-site support where you can have telephone support to officers. That's happening more and more, I think, with COVID even. Video conference support where you have a behavioral health clinician kind of on standby at the ready, just like they may have medical supports that come in by video. Mobile mental health crisis teams that either are embedded in that police department or are coming separately and may co-respond to a scene together with specialized protocols and policies, and then specialized emergency medical services. I often think of this as the three-legged stool. If there's an emergency and you call, who's going to come? Is it going to be your EMT, your mobile crisis, and your law enforcement? All the more reason that those should be partnering together and develop shared policies for best practices We have also other types of specialized emergency medical responses that are getting a lot of press right now. The CAHOOTS model in Eugene, Oregon, for example, which is a model that stems out of an FQHC where they will go and respond to crises, very rarely involving law enforcement. It started as an intervention for homeless persons in crisis. Next slide. So we also have targeted diversion for nuanced populations. For example, for people with substance use disorder, the Seattle LEAD model is something that's kind of swept the country in terms of excitement, which is the law enforcement assisted diversion, which takes people with substance use disorders and low-level offenses and diverts them into care. Police assisted addiction and recovery initiative in Massachusetts, human trafficking diversion models, prostitution diversion models, homeless outreach teams, and the like, all at that Intercept 01 interface. Next slide. Then we get into Intercept 2. This is once a person has been arrested or a criminal complaint has been filed, and there's an initial detention period and a first appearance in court. And any one of these are spaces where opportunities for intervention and diversion can be created or enhanced. Next slide. So what are some examples and why is Intercept 2 important? Well, Intercept 2 we think of as a very important place because this is the first place where people are actually held in a locked facility. And as we're talking about behavioral health challenges, it's often a place where people become destabilized. They may not have access to their medications. They may not be able to report what medications they were taking. They may exhibit suicidality. But also, if we just look at general population, what does it mean to be locked in a setting? This Kentucky study was pretty enlightening to many of us, which basically showed that if you detain low and moderate risk defendants, you will increase their rates of new crimes. If they're held for 2 to 3 days, the low-risk defendants are 40% more likely to commit crimes before trial. If they're held for longer, 8 to 14 days, the low-risk defendants are 51% more likely to commit crimes 2 years after case disposition. Now, this wasn't specific to people with behavioral health needs. This was a general pretrial detention population. But just like we learned in juvenile justice, a day in detention has impact on that person's likelihood to recidivate. We're seeing the same thing in the adult populations. And so we have to pay attention. You know, obviously detention plays an important role in our society, but we want to make sure that we're detaining, I always say this, the right people at the right time for the right reason, and diverting those that don't need to be detained. Next slide. So we saw in the MacArthur Safety and Justice Challenge the impact of COVID, where a lot of people were released. Very interesting, without any increase in violent crimes as more and more people were being released. So as Dan said, you know, we may be seeing something that can be sustained and change even beyond COVID. Very interesting to think about how jail bookings were able to go down because of COVID, and to date, haven't seen those negative impacts. In fact, if we really want to think about what enhances public safety, if we look at that Kentucky data, we really do have to question about those detention rates that were pre-COVID. Next slide. There's also a lot to be said, you know, at that detention level, it can happen at the local lockup, but often it'll happen in the jail that's got a partnership with the local lockup. And there's a lot of healthcare models where the jail employs healthcare staff, and it'll contract with the national. Jails have different ways of contracting for healthcare services. Essentially, they may contract with the national healthcare vendor. They may contract with local or private or public providers, or county health departments are providing the services within the jail. And how the jail is structured for its healthcare and its behavioral health care may have impact on whether that person is connected to services upon release. Next slide. There's also the special populations that have specifically designed interventions. For example, the VJO model of services. In Maryland, you have a VJO in a couple different regions, and these are some names that were on the local website. And essentially, the VJO initiative was designed to help veterans who were in justice settings to help coordinate aftercare post-release and help make sure that reentry and diversion opportunities are available to them through the VA. Next slide. Then we move into Intercept 3, which is the jails and courts. And at Intercept 3, again, very important because the opportunity to identify individuals with behavioral health challenges and then move them out of the justice system and into the treatment system, very important. Next slide. So here we have a lot of examples of what's going on. The Stepping Up initiative is an initiative that's funded by several different entities, including the American Psychiatric Foundation, the National Association of Counties, and others. And essentially it says that county leaders should convene and sign a resolution that is committed to reducing the population of people with mental health and substance use needs from the jail population, and work together asking 6 key questions about commitment of leadership, looking at data, and moving to decrease that overall number, stepping up to reduce that number. And there are several counties in Maryland that have signed those agreements. Next slide. We also see at the jail and court level that if the in-jail services are assessing custody needs and accessing medications, mental health services, and substance use services, and then communicating with community-based providers, we see enhanced connection upon release. There's some data that came out of our Michigan Mental Health Diversion Council. Dr. Cheryl Kubiak is a leading researcher in this area. And when they examined our jail diversion programs in Michigan, she found that individuals receiving an in-reach or diversion service while in jail were twice as likely to receive a mental health service in the community as opposed to potentially getting lost to follow-up. And so this is where it's really important that the in-jail services are not ignored as we look at the SIM planning effort. It's not like, well, that's a black box that doesn't matter. It really does matter. Also, there's a connection between the in-jail services and what will happen with the treatment and problem-solving courts. They're very interconnected systems. And so we really want to look also at problem-solving courts, which are usually considered alternatives to incarceration, but yet they may interplay where there may be sanctions that involve incarceration, and so that in-jail service will be relevant. But the treatment and problem-solving courts, very important. Drug, DUI courts, mental health courts, veterans courts, and other types of courts. Go to the next slide. What about healthcare integration? Across these intercept lines, it's very important that we think about integration of mental health, substance use, and healthcare overall to ensure a holistic approach to how individuals are benefiting from services and helping them remain stabilized. And this includes through Intercept 0 and 1, the crisis lines that are rolling out, the 911 and the 988 numbers, how those are going to work together, and the entire crisis care continuum, the Intercept 2, what's happening at that pretrial stage, as well as in the booking stage, and then at Intercept 3 with the jails and the courts, and making sure that we're screening for the proper conditions, and then enforcing and ensuring that people are getting access to care. There should be continuity of care. I always say, regardless of the walls that are built around an individual, their condition, whether it's diabetes or schizophrenia, their condition should get the same treatment in all of those settings and as they move across. So that's going to be important for us to be thinking about as we build out opportunities to close gaps. Next slide. All right, Intercept 4. Dan, I think this is where you take over.
It is. Thank you, Dr. Pinals.
All right.
So Intercept 4, we're not talking about diversion anymore. We're talking about reentry and engagement in services. Next slide. So we've made this point earlier, right? Reentry is a matter of life and death. That followed the study out of the state of Washington following over 30,000 prisoners found that the mortality rate was 3.5 times higher than the general population. And within the first 14 days of release, 13 times higher than the general population. Drug overdose, heart disease, homicide, and suicide were the primary causes of death there. And so this is a pretty busy slide, but the point I want to make, and Dr. Pinel's referred to this about how jails and prisons actually design their healthcare services and how really the state structures its payment strategies can have a big impact on integrating healthcare. So what several states have used their Medicaid managed care contracts to require plans to conduct in-reach into prison. And this really is a best practice. There's very good research that shows in-reach into prisons, meeting somebody prior to release, enhances engagement following release. And you get better health outcomes and you get better justice outcomes when that in-reach is being done. So states, as a result of the Support Act, can get approval for Medicaid funding to do this. Ohio's done it. They have their the state Medicaid plan will pay for local providers to in-reach into the jail and to the prisons to begin the enrollment process, get them enrolled in Medicaid services, and then, more importantly, provide transition case management and a fixed appointment for people upon their release. And that provider that's identified through the plan becomes responsible from the transition out of the jail prison back into the community. And New Mexico has a similar strategy. So again, these are the funding piece is a very important piece and something that states can certainly enhance through how they're using their Medicaid and other funding strategies. Next slide. So if anybody's ever been a case manager in their life, this is your slide. You know the work that you have to do. Next slide, hit it again. And again. So, and the reason why care coordination is so important is that the needs of the population that we're working with are many, and they touch multiple systems. It's overwhelming for somebody coming out of a jail and prison to make all the appointments for their health care, try to find housing, go to the pharmacy for the medication, and transportation and some of their basic survival needs have to be met. And there's multiple systems that they have to deal with. Without care coordination, if you're being released with disabilities, even without disabilities, it's a tremendous challenge. So that piece is critical to design into the programs. Next slide. And public benefits are key. You have to pay. It's very hard to get services if you can't pay for them, and the Affordable Care Act certainly has enhanced access to services. And Maryland was one of the early adopters of that. I know that there are jails in Maryland that brought Medicaid workers into the jail to enroll people so that they could be enrolled coming out of the jail. One of the first states to do that. Social Security, SSI, is also a big benefit for people who are disabled, and the SOAR initiative, and Maryland's been a big SOAR state forever. I mean, Marion Bland, we've worked with for, I don't know, maybe 15, 20 years, not to tell stories on ourselves, Marion, but and this is a strategy to ensure that somebody gets a social security disability through following a specified process and training within 90 days of release. And to the extent that these SOAR initiatives and the resources to put disability enrollment specialists into the jails and prison really will enhance your outcomes. As there's some research that out of Oklahoma and Miami-Dade that shows that people who have social security disability, whether they're in their mental health courts or coming out of jail and prison, have better outcomes. Next slide. And then the last is Intercept 5 with probation and parole. Next slide. We talked about the numbers of people under correctional supervision, and the greatest number is under probation supervision. Next slide. And specialized caseloads are a promising practice. We find that they reduce, they improve linkages to service as it reduce the risk of violation. And that their probation is using some of the best practices in terms of validated assessment tools, training officers on motivational interviewing, case planning, and focusing on criminogenic risks to ensure that people are getting the right levels of supervision. Next slide. So, and this will be my last slide. Healthcare integration in intercepts 4, 5, and across intercepts. This is, again, across the system, we want to look at opportunities for the justice system and the healthcare system to be better integrated. So again, in intercept 4, funding is important for those, and benefit access is important for integration. In-reach services is important in transition case management, and many jails and prisons now have integrated their medication-assisted treatment protocols from jail and into the community. In Intercept 5, co-located behavioral health providers working in probation offices or parole officers. And then across intercepts, data is important, strategies for information sharing, and addressing housing and homelessness. So that the justice population is included in an overall homelessness plan. So that's my last slide. I'm going to turn the session now back to Senator Hester to introduce the moderators for the panels.
I think we may have time for a few questions.
Okay.
Just one or two. If anybody has a specific question, can you message Dan or Deborah from the SAMHSA Gain Center directly? And you guys just check and see if there's one or two you want to answer.
Sure.
Do you see any, Dan?
I don't see any yet. No.
Okay. You answered all of our questions with that phenomenal presentation.
I must have. We must have. Yeah, my computer isn't frozen, but so I don't see any more chat.
And we haven't lost anybody either. Our numbers keep growing up. We've got over 220 folks here on the Zoom and more watching on the YouTube. So I guess, Deborah, unless you have specific questions that have come into you, I will then move on to our next.
Go ahead. There was one person, Dan Martin, says he has a question. Oh, actually, there were a couple. Too long to type. So, and then another person, so I don't know if they can speak. Can people speak or no? Dan Martin? But I'll ask another question that somebody asked.
I can speak if I'm allowed to, if there's time. I just had a question. Well, first of all, I mean, thank you very much for this presentation. It was really wonderful. And thank you, Senator Hester and everybody else for putting this whole summit together. I think it's really great. And I really appreciate, that we're talking about kind of looking at these things through a race equity lens. I think it's really important. But I think what I wanted to kind of throw out there, just kind of thinking, out loud, is if, we're really wanting to look at things through a race equity lens, I think we need to start thinking about, Ms. Penal, is that how you pronounce it? You talked about, just recently starting, putting getting to an intercept zero, creating this intercept zero because we wanted to get ahead of kind of law enforcement, head of interaction with law enforcement. And I think if we're really looking at things through a race equity lens, we might even have to go a step back further to a kind of an intercept -1. I think crisis is actually too late in a lot of instances. Black and brown youth, Mr. Abreu, as you mentioned, face more traumas, than white youth. They have more adverse childhood experiences than white youth. Minority populations have more traumas that lead to kind of, more mental health and substance use disorders. But these populations have less access to behavioral health services in the communities and related support. And when they can access those services, they're more likely to get less quality care, and this is a structural issue that leads to Black and brown people, getting to crisis unnecessarily when these issues probably should have been able to be addressed earlier on. And so I just wanted to kind of throw that out there, saying that just kind of, to say that, I appreciate looking at these things through a race equity lens, but if we really, really want to start looking at that, we have to get even farther upstream than crisis services.
I think that's an excellent point, and I'm really glad you raised it. And I want to say, I think you're absolutely right. And so, the SIM model was really designed to divert people from the justice system at a certain point in time. None of what we're saying negates the absolute need for prevention strategies, for looking at community-based recognition. The issues around race and equity in healthcare intersects the issues of race and equity in the justice system. You could look at the juvenile justice system. You could look at multi-generational impacts, and that's a big area. There's a lot of work going on between child welfare and the children's behavioral health system, getting prevention, I know Maryland has some great programs going on in those arenas. So I think all of that is very, very relevant. And the more you get into this, the more you start to say, oh, what if we did this upstream thing? And what if we did this upstream thing? But I think the way I look at this is, even though it has to be depicted linearly, because everybody's now like flat on a screen right now, it's not linear. It's very circular. It's almost like a glow. Everything intersects with everything. And it's a place to start. I think this, for me, having done this again in multiple states, the SIM provides an opportunity as a place to start the conversation. It definitely doesn't end the conversation. And so I love your points that you made. I don't know if there's time for another question. There was one other that came to me. Is there time for me to address it?
I think if you can address it in like 60 seconds, that would be great. Okay.
What efforts are being made to increase the number and access to case managers and care coordinators? Where would individuals find them? Workforce development is an area of need. If you all identify in your gaps tomorrow that that's a major issue, then I would urge you to put that down and develop strategies to enhance that workforce. I mean, there's a lot of things going on in that space in terms of pay, in terms of schooling, and we've done a lot to educate people to do mobile crisis in Massachusetts. We worked with schools actually to build a workforce. So there's things you can do, but you have to identify that first as a gap that you want to prioritize. That's what I would say.
And so I guess we'll identify that tomorrow. Thank you guys both so much for an excellent first panel and a kickoff of where we're going for the rest of the day. Just before we dive into our next panel, I'd like to acknowledge that we've received several requests for copies of the slides used for today's presentations. And we will be distributing those to all who have registered at the conclusion of today's meeting. So thank you very much. I think Matt is also going to try to compile a list of questions, which hopefully we can address when we send out information. So with that, I would like to welcome our panelists for our 10 o'clock panel. This is Intercept 0 and 1, and that's community services and law enforcement. I'd like to welcome our moderator for this panel, who is the chair of the Senate Judicial Proceedings Committee, Senator Will Smith. And Senator Smith and I had the pleasure to serve together on JPR in 2019 and still both serve in the Senate in Annapolis. Senator Smith has been a member and a champion on this issue for a long time. He's been a member of several key work groups, including the Justice Reinvestment Act, the Law Enforcement Officers Bill of Rights, and most recently, he's been leading a group to look at police reform over this year. He will be joined on the panel by LaWanda Williams, the Chief Behavioral Health Officer, Healthcare for the Homeless. Also, Lucy Bill, Mobile Crisis and Law Enforcement Assisted Diversion Manager from Shepherd Pratt in Washington County. And Jen Corbin, the Crisis Response Director from Anne Arundel County Mental Health Agency. and Lieutenant Steve Thomas, Anne Arundel County Police Department. So I'd like to welcome you all, and I will turn it over to Senator Smith to moderate this next panel. Welcome.
Well, good morning, everyone, and thank you, Senator Hester. First, I want to say just thank you for all of your stellar work around this issue for the time you've been in the Senate, even before. I know you're the co-chair of the Public Safety Subcommittee, and so I want to say thank you for all of your work and for bringing us all together. Also to the Lieutenant Governor for his work in this issue, and for Steve Shu. Good to see you, and thank you for your work as well. As Senator Hester mentioned, we're here today. We're going to discuss Intercept 0 and 1, which focuses on community services and law enforcement. And before we start off, I'll just say that our work in the Senate has around this issue is in recent months has largely been influenced by the racial reckoning and the national uprising and our renewed conversation on some of these issues that many communities have been dealing with for generations, but have now percolated up to the top of everyone's consciousness, now top of mind in the national dialogue. So obviously we're in the midst of a political moment where we're looking at reforms in law enforcement and obviously criminal justice. And some of these issues that we're dealing with may not have been politically possible or palatable in years past, but if now we have a political moment where I think we could have some frank and some refreshing conversations on some of these issues around systemic injustices and systemic inequities that have persisted for generations. So I know that we're going to take a comprehensive look, and this panel will help us reveal some of the steps that we can take before someone gets incarcerated, during their period of incarceration, and even some of those options for pre-release. So I'm really excited to learn from the panelists and to understand some of their work on a more intimate level. Now, obviously, I'll just say this before I kick it off to the panelists. In recent months, I've had opportunity to travel around the state, and something that was said to me when I was up in Baltimore City, visiting a violence intervention or interruption program. And one of the men that was taking us through the city said that, in certain neighborhoods, that law enforcement officers are the most prevalent and predominant instrumentality of government that these people ever interface with. And so that's something that when we're reimagining and we're trying to retool our criminal justice system and understand certain opportunities that we have at our disposal, that's something that really resonated with me. And so as we move forward with ideas about training and competent cultural and social competence, and augmenting our responses to folks that are going through a mental health crisis or addressing some sort of social ill, that's something that I thought was pretty instructive and informative for me. So with that, I'll kick it off to the panelists. As Senator Hester I mentioned before, we have Ms. Williams, we have Lucy Bill, and we have Jen Corbin from the Crisis Response Director from Anne Arundel County, and we have Lieutenant Steve Thomas from the Anne Arundel County Police Department. So let us start off with LaWanda Williams. Ms. Williams, if you would cue up your presentation, and we will start off with a presentation from each panelist, and then we'll have an open up for a Q&A afterwards. So with that, Ms. Williams, you're on.
Thank you so much for having me today. And I'm really looking forward to talking with you all. Just getting my slides here. Here we go. So again, my name is LaWanda Williams, and I am the Chief Behavioral Health Officer at Healthcare for the Homeless. And I'm going to spend some time today really just talking about homelessness and reentry and how that shows up in our work, and really from a frontline provider perspective. I should share that I am a public health professional and also a licensed clinical social worker, and have been working at the intersection of homelessness and healthcare for over 16 years. And so really pleased to be with you all and share with you the work that we've done and working and serving individuals who've been justice involved and coming back, returning to our communities. So I'll start a little bit by telling you just who we are. So Healthcare for the Homeless is a really large and inclusive community, and we serve nearly 10,000 people who engage in our healthcare and supportive services every year. We have a staff membership of 230 staff members, and that's growing. We have a board of directors of 28 members. We have a number of corporate and local and state and federal funders who support the work that we do at the organization. We have a very wide network of community partners and volunteers that add to the richness of the work that we do. And certainly we would not be able to do the work that we do without having many of our advocates who themselves have intimate relationships with homelessness. So we have a very strong consumer advisory committee as well. In terms of who we serve, we use the U.S. Department of Health and Human Services definition of homelessness to define the population that we serve. So this includes individuals and families who are living on the streets. They might be living in shelters or transitional housing programs. Many of our clients, unfortunately, live in abandoned buildings and vehicles. Many are doubling up, couch surfing, living with neighbors and friends, and living in other sort of precarious and non-stable, non-permanent living arrangements. And the numbers of people who we are serving who meet this definition, unfortunately, is rising. We know that COVID-19 has had a really hard impact on individuals and housing stability. We know that thousands of people are facing eviction every single day as it relates to not being able to pay their rent and maintain stable housing. We also know, as it's been mentioned earlier, that we are at a space where COVID-19 has sort of elevated many of the racial disparities that already existed within our communities, and we see Black and Brown people being disproportionately impacted by housing instability and finding themselves coming into our care. So what we do in a snapshot, we provide comprehensive healthcare services to people experiencing homelessness, and we also provide supportive services to those individuals as well. We apply a whole person approach to the work that we do. I'm really considering all aspects of someone's life and health and their wellness. So really thinking about the provision of wraparound services. And then we also have a very strong advocacy component to the work that we do. And we strongly advocate for housing, affordable, decent, quality housing, and livable incomes for folks that we are serving. To provide a little bit of context, our Healthcare for the Homeless in Baltimore is a part of a national Healthcare for the Homeless program. And it is a part of the HRSA Health Center program. We are a federally qualified health center who are serving special population groups. There are over 330 HCH programs where we served over 1 million patients in 2018. The vast majority of our clients that we serve are, between 50 and 65 years of age. These individuals, again, are living in shelters and transitional housing programs. Some of our clients are living in supportive housing programs and are doubled up. And our HCH providers, just to provide some context, provide a lot of comprehensive physical care, primary care, mental health services. We provide addiction services. And actually in 2018, our MAT providers across HCH programs provided services to over 32,000 patients. So I'll center and tell you a little bit about the work that we do in serving individuals who are just as involved or who have been just as involved. One of the things that we have seen in our work is that many of our clients who have been within the criminal justice system have poor health conditions. And we know this as a reality for many people who are experiencing homelessness. We know that a lot of the ailments and disease processes, in particular diabetes, and in particular hypertension and some of those other sort of coexisting comorbidities show up more frequently and much earlier in life. So where you might see someone who is, dealing with a chronic medical condition that would typically present itself in the 60s or 70s, you're seeing those things manifest themselves in 40s and 50s in our population. There is an intensive need for complex care across many systems and many providers. So when someone mentioned case management earlier, it can't be underscored that the need for case management and targeted and specific case management, specifically working on issues that are intrinsic to people who are returning from incarceration, it's absolutely critical. We know that individuals who have been justice involved as well have a really high risk of overdose. It bears some stopping here to say that within the context of COVID-19, one of the things that we have seen has been an increase in overdoses. We are in a time right now where much of the things that we are required to do to keep ourselves safe and healthy and that are absolutely best practice in public health also are very much in conflict with how people oftentimes will use substances. So if people have coexisting opioid disorder, as an example, and are coming out of prison or have a history of justice involvement, one of the things that people often do to keep themselves safe is to use substances together. And so now that's not something that people can do because we have to be physically distant. And so it bears repeating that there's some real big need for us to reimagine and think about how we deliver harm reduction services and the kinds of care that we provide to people, particularly when they've been justice involved. Another critical time is that when someone's coming out of prison, we often, or out of incarceration, we will see that people's systems are typically naive. And depending on how long people have been incarcerated, that becomes more of a problem. So if people are coming out and starting to use the same level of substances they had before, we see the overdose potential be very, very high. One of the other things that we see is that there is often a lack of health insurance and no benefits. At Healthcare for the Homeless, we have a SOAR outreach department that actually targets individuals who have substance use disorders and behavioral health disorders, and particularly individuals who are coming out of the justice system and helping them to access and apply for SSI benefits and SSDI benefits. Often our clients don't have documents that require them to get access to other things. And so we spend a lot of time helping people to get IDs, birth certificates, all of the critical identifications that validate someone as who they are, that allow them to then get access to things like housing and other services. We do a lot to help people connect with medications. Certainly, if someone does not have medications, our clinic, we are able to provide medications and cover those costs for individuals who might not be insured. Employment, as someone mentioned, is certainly an issue, in workforce development in particular. Many of our clients, again, don't have housing, or there's no stability in their housing situations. We will often find that when people are coming to us, they're sort of moving back and forth between various places, trying to create a cohesive plan, and that can be a bit disjoint and often be an impediment to consolidated and consistent care. Oftentimes, people have few constructive support systems or no community support at all. It's not uncommon that many of our clients will refer to us as their family and will want to use us for things like emergency contacts and those kinds of things, because that system has not been fully developed in terms of their community support network. So a number of challenges exist in treatment, obviously, in working with individuals who have been justice involved. Medical and behavioral health conditions, they actually go beyond case management. It really requires a holistic care approach with multiple healthcare professionals involved in that plan of care. Client incarceration histories in and of themselves can be a barrier to housing placements. In Healthcare for the Homeless, we are serving over 400 individuals in permanent supportive housing. And I'll tell you, one of the things that comes up very often is that there's a need for advocacy in the housing space to increase the pool of landlords who are open to the idea of thinking creatively about someone's ability to come back into the community and live as all of us want to. One of the things that we always talk about is that our programs are housing first. So in saying that, we don't require any sort of background checks or extensive things for people to have to do, or sort of extra hoops they have to jump through to get access to housing. We believe that just by product of being and living and having breath in your body, you're ready for housing. And so we often sometimes spend a lot of time convincing our landlords of the same. There's a lack of, particularly our ability to share data with prisons. And I think there's a real opportunity there. And sometimes the release of the terms of people's release often are in conflict with harm reduction models of care. We know that as people start to make progress with modifying their substance use, one of the things that happens is that we often will find that clients are in that process and not quite there yet and need a different kind of care. So, and then again, we also are thinking about conflicts in management with landlords and care teams and that sort of thing. So I'll want to be really brief and share an example of Mr. Ross, who is a client of ours who has spent a very long time in his life from the age of 15 within the criminal justice system. And in 2012, Mr. Ross was able to integrate into care with us and actually has been quite successful in addressing some of the substance use issues that he's had and has been outside of the criminal justice system since 2012. He had not, since a young man, had been outside of that system, either incarcerated or parole or probation. So this is absolutely something that I think in terms of looking at the Intercept model, there is utility in thinking across all of those systems and really thinking on the front end about prevention and how we provide some of the things that are more in the realm of the social determinants of health that really help people to even prevent themselves from getting into the criminal justice system. And just a few strategies I want to wrap up, but just in terms of enhancing services, we think a lot about prisons and jails and requiring said treatments, all forms, behind the wall, thinking about auto enrollment for Medicaid prior to release, really thinking intentionally about treatment capacity and making sure that we have the ability to provide appropriate caseloads for individuals doing this work. Workforce development and employment, finding and helping connect people to jobs that provide sustainable, livable wages that can actually meet their basic needs. And then access to housing, linking people to SSI, creating more affordable units within the continuum. So I will end there. Thank you so much for having us, and looking forward to the conversation.
Thank you, Ms. Williams. And thank you so much for your work. This has been a great presentation, and thank you for sharing the story from Mr. Ross. Now, obviously, we made some strides in Maryland, the source of income discrimination for those vouchers, but it just shows the intersectionality. I mean, that was a lot of people focused on unleashing economic opportunity for folks to be able to move wherever they could around the state, but this shows that there's a real effect on recidivism and making sure that people are stabilized. So thank you for pointing that out, and thank you for lifting up his story. I'm sure we'll get more into that in the Q&A. So next we'll move on to Lucy Bill from the Mobile Crisis and Law Enforcement Assisted Diversion Manager from Shepherd Pratt in Washington County. So Lucy, you're up next. And if Lucy is not in the queue, then we will move on to Ms. Corbin. Jen, are you able to Roger up here?
Yes.
Okay, great.
It'll be me and Lieutenant Thomas together.
Oh, perfect. Great. Good to see you both.
This is Lucy here. I'm just trying to get access to my slides here.
Okay, great. So then Jen and Steve will hold off, and we'll
sorry for the delay.
No worries.
Well, if that's not working, I'll have to get some technical assistance.
There you go.
Okay, thanks for bearing with me, everyone. So, thanks for having me. I'm the manager of the Law Enforcement Assisted Diversion Program out in Washington County, and I really find it helpful to start with a little bit of a national context and the story of LEAD. For anyone who doesn't know, the model actually started for this system of organization born out of a case that the ACLU had opened against the Seattle Police Department to address a lot of the racial disparities in police enforcement. And every stakeholder at the table, as we are here today, was looking for a creative solution, and finding themselves at the point of impasse, they eventually developed this unprecedented collaboration. That Seattle group refined some really clear goals and core principles that you can see there in the chart here from the Lead National Support Bureau. They really formalized this idea of diverting an individual from the criminal legal system right at Intercept 0 and 1 with a partnership with law enforcement and service providers, and getting people instead into intensive case management services with this really robust harm reduction mindset. The model has had clear success and has been a clear goal for many areas. There's now about 40 jurisdictions nationally operating LEAD programs, and that's certainly a rising number, as Lieutenant Governor mentioned this morning, especially in Maryland. In Maryland specifically, the opioid epidemic has been reframed as a public health emergency, and those of us involved at Intercept 0 and 1 really recognize the vast gap in public health service availability and access. Most of us are all too familiar with that no man's land between prevention initiatives and treatment for behavioral health issues. It has been discussed pretty thoroughly this morning. That gap is often inherently filled by the criminal legal system, and the only tool available there is a cycle of arrest and incarceration for all those low-level offenses. I mean, officers have this situation in front of them that qualifies for charges legally, and there's this duty to uphold that. So the Maryland Department of Health and the Governor's Office of Crime Prevention, Youth and Victim Services in Maryland wanted to expand a model or program that could fill that gap and provide law enforcement with an alternative to arrest. The Maryland Department of Health Regrounding Our Response initiative is based in a harm reduction mindset, and it's really in everything that we do in LEAD, particularly in Washington County. And it takes into account the importance of a lot of the elements that are part of the Regrounding Our Response initiative, like stages of change, adverse childhood experiences, social determinants of health, and the drug user health framework. Maryland has, as has been discussed, knows, I'll use Maryland as a large term, if you want to begin to reduce harm to individuals in crisis and their community, the focus, of course, has to be on addressing the underlying issues that might cause an individual to be in contact with the criminal legal system in the first place. So particularly looking at chronic homelessness, substance use, mental illness, things like that. With high rates of overdose and fatal overdose in Washington County, we already had some robust harm reduction services in our community, and all partners that came to the table, including law enforcement, were really naturally interested in the prospect of all the principles and practices essential to LEAD, and it was really already making sense to us. We were looking for something to fill that gap. Again, going from the Maryland Department of Health and the Governor's Office of Crime Prevention, Youth and Victim Services, they reached out to Washington County. They reached out to me already in this place of leading the mobile crisis services in Washington County. Those state entities lent their foundational experience and a lot of expertise that they already had from the successes of Baltimore City's LEAD pilot, and they offered us a lot of technical assistance for startup and securing funding. We had train the trainer events, and they really have supported essential training for law enforcement and service provider partners. Being the identified program manager, my primary role in the implementation phase was to enact a lot of the core ideas of the SIN model discussed thus far. So I identified and brought together a lot of existing entities and people already interested in harm reduction and making change to the criminal legal system in our county, bringing them together to provide more effective and appropriate supports. So our community was really already naturally attempting to fill in the system gaps between prevention and treatment. They're already trying to do that on their own. So there were case management providers, harm reduction services, and even individual officers working separately to connect and stabilize individuals in crisis and trying to keep them out of contact in this like chronic recurrent contact with criminal legal system. But as discussed entirely today, those services were disjointed or just had difficulty connecting. So LEAD is really this organizing principle that brings all those entities to the same table and streamlines and organizes all those services into something that's coherent and actually accessible for lasting diversion. Once we got underway, we identified the partners that were going to be essential and part of this model. We really wanted to target diversion from low-level offenses such as trespassing, charges related to sex work, possession of substances and paraphernalia. The structure and services of LEAD can actually provide officers in the community an alternative to arrest for those types of things and an alternative to using the 911 system for situations that are far better addressed by intensive service interventions. As with all elements of LEAD, things like what divertible offenses a county chooses to use, eligibility structures, but it made sense to our stakeholders that there would be 3 different types of referral options to fit the variety of charges, provider availability, and individual situations. So our stop and criminal summons referrals involve any situation where there's an evidence for a potential charge, but the responding officer instead diverts the individual to LEAD services and engages in a warm handoff to the provider. After a referred participant has completed just one meeting with a LEAD service provider, they're considered fully enrolled in LEAD, and any potential charges related to the referral are removed completely. If enrollment doesn't occur right away for whatever reason, the charge can still be shelved for a year and a day, and only in certain cases is it ever considered for reopening. I think we get a lot of questions around this area, of course, but the charge can be a motivating factor for engagement, but our services are intended to be low barrier to entry, so charges aren't in any case coercively held over a person's head. So social contact referrals are unique to LEAD and really important to us in our county. They include any referral made for an individual who has a history of contact with law enforcement or who's identified as at risk of entering into contact with the system, but they're not presently engaged in a situation that involves potential arrest. So LEAD in Washington County, I'm proud to say, really experienced a natural shift early on to promoting referrals from sources outside of law enforcement. We really wanted law enforcement and service providers to truly apply their skills and the techniques that they have where they're actually needed and most appropriate. So as such, we accept social contact referrals in our county from any community entity, and that really allows for the fact that law enforcement does not have to be involved for diversion to occur. And I would say in acknowledgement of the movement for Black lives and discussion on the over-reliance on police for public health, public safety, and order, this continued emphasis on a social contact style of referral is supported by the LEAD National Support Bureau, and it only continues to make sense to all of us involved. So once a participant is successfully identified and connected to LEAD by any of those types of referrals, the key element of ongoing operations is intensive service provision. That's really what makes the diversion stick and work and is what makes LEAD effective. These providers support diversion and reduction of harm for the participant and the community. Our services team is made up of case managers and peer recovery specialists, and any participant can choose at any time whether they want to engage with one or both elements as it fits their needs, interests, and comfort level at the time. In this model, we're working with individuals, as you all know, for whom traditional services have not often worked. So we're able to provide services in a different way that doesn't adhere to specific criteria for engagement that's usually imposed on traditional services. Things like time limits or expectation of a certain number of services a month. So this means we can actually adapt interventions and supports to an individual's level of need and, of course, their stage of change. It also means that an individual is never actually discharged from lead. I mean, aside from a few specific cases, no one's ever actually discharged. So we sort of expect a flow of engagement and disengagement with services. That's considered natural in the process of harm reduction and lasting diversion. Existence of what's referred to as the operational work group is another really invaluable tool for successful diversion in the LEAD model. Our operational work group currently meets about twice a month, and we have consistent representation from our key partners. That's Sheriff's Office Police Department, myself, the Health Department, Case Management, and the Office of Public Defender. I think it's really essential that we keep each other up to date on cases and we collaborate to brainstorm together on best next steps, because we have an understanding of what each entity can do and provide and what our limits and abilities are. So we're able to actually collaborate on those cases. And that intensive partnership and accountability in the work group meetings is really the root of what makes LEAD an essential model for this kind of implementation at Intercepts 0 and 1. I've been running through a lot of information here, but I want to take a second to really focus on some of the things we've noticed or want to point out as notable, because we've been in operation now in Washington County for a little over a year. The policies and procedures we've introduced in LEAD, I think maybe people are thinking about this already, but those things can prove jarring or even cumbersome to some officers. And it's generally quite a cultural shift, even for the officers that were eager to engage with the program. So I've recognized this past year just how important it's going to be to reinforce LEAD's core principles and goals through things like refresher trainings, in-services, and to really re-energize patrol officer engagement with the referral process. An example of why this is so important, most of our referrals have come from our Washington County Sheriff's Office deputies this past year. So naturally, the demographics of our referrals are thus going to match the demographics of the population in the Sheriff's Office boundaries. So that population is predominantly white, just naturally the population of that area. So being well-versed in the core principles of LEAD, our partner from the Sheriff's Office actually took note of this correlation, and he brought it to the operational work group's attention. And as a result, now much of my referral and engagement efforts can be targeted specifically now towards the Hagerstown Police Department, as most people of color live within their service area, and it's imperative that we ensure that we're providing opportunities for diversion to all community members. Another element of note, I would say, is our high proportion of social contact referrals in our county. About 75% of participants have been social contact referrals. I'd say we're most proud of this fact because it really shows how dedicated our law enforcement partners are in Washington County to diversion and to removing themselves from the equation as quickly as possible. Most often, our law enforcement officers have been making referral suggestions right into our operational work group without having to have any new contact with that individual and no pending charges. As we look to expand in this direction, one new partner for social contact referrals is going to be the Public Defender's Diversion Linkages Program. And this should serve to create an even more seamless transition for individuals who might already be engaged with the criminal legal system, transition from incarceration to be supported in reduction of harm and reduction of recidivism. So this direction that we're heading, again, I'm really proud of that. And even in just this 1 year of operation, and this direction we're headed continues to allow us to really start to get at the core goals and concepts of law enforcement assisted diversion in our community.
Lucy, this is great. Thank you for all the work you've done, and thank you for sharing this great work and the results that you've had. had. And I think it'll be instructive for the rest of the state to learn some of those lessons that you've been able to tease out here. So, and it just underlines that, you know, when we move into this conversation about reprioritizing and focusing more on intervention and ensuring that our brave women and men in law enforcement have the tools they need to appropriately address those societal problems, this is a core element of that. So thank you very much for your work and for sharing your best practices and lessons learned. Come to JPR, we need your help. So with that, we will move on to our next two panelists, Jen Corbin and Lieutenant Steve Thomas. So Ms. Corbin is the Crisis Response Director from Anne Arundel County Mental Health Agency, and then Lieutenant Thomas is from the Anne Arundel County Police Department. Over to you all.
We're having difficulty controlling the screen, sir.
There you go. We can see you now. We've got your presentation up.
Okay. Oh, okay. So we're going to start, and it's more important talking about what programs and interventions we do, but actually how we got started, where we are today, and the mindset of crisis response in the police department that we are fully integrated. So Crisis started in 1999 under a grant, whereas the first collaboration between the police department and crisis response, which laid the foundation for where we are today.
He moved.
So with it, we have our crisis response teams. It's 2 licensed clinicians on police radio, police call signs, responding to police calls for service that are not traditional police calls for crimes. The mobile teams actually attend police lineup and work and strengthen that relationship with the officers to help in non-traditional policing.
You moved this one. It didn't change.
You might have to advance us because.
There you go.
Okay,
yeah,
thank you.
Thank you. So the uniqueness here is that the police and mental health clinicians are working together. What I mean by that is being on police radio, the officers out in patrol have the discretion of calling out a clinician whenever they feel that is needed. What is unique is there's a kind of a setup on how that should happen. Really, whenever an officer feels they need assistance from a clinician, they actually just radio right on police radio, and we respond immediately. A lot of the things that we do see patrol calling us out for, of course, are the mental health issues. But also now we've seen an increase in traumatic events, juvenile issues, substance use, family violence, and actually elderly issues as well. So I really kind of like to say any social situation that police are encountering that they feel like they need some assistance with, they can radio for us to come out and work with that individual. And it helps free patrol back up to get back on the radio for the next call for service, and allows us to provide those interventions as needed.
So last year, those teams responded to over 2,100 calls for service where police called them out, and then did additionally almost 6,000 follow-up calls. So our integration in 2014, and this was really a Jen concept, where she went to the chief and talked about that she wanted to create a crisis intervention team as well as a peer support team, and both happened at the same time. So it's really to understand the significance of having both, that it created a culture of caring among the police department and the partnership and integration with crisis response.
And the reason that I asked for this was there were about 30% of the calls that our mobile teams were going on where I felt like we needed an officer to either stay, or we weren't even making it to a call due to the safety or the situation on scene. And so I felt like there was a missing piece there in that puzzle, which is kind of what gave me the idea of, let's send them through the CIT training, but instead of just leaving them in patrol, what if they become the partner with the clinician? One of the big things that Steve and I are passionate about is that when you work as a team, you kind of wear off on each other. So the clinical piece wears off a little on the officer, the safety piece wears off a little on the clinician. And so when you work together in that setting, it really builds a bond with the person that you're on the call for service with.
So one of the important things that we did back in the fall of 2015, we trained every officer in mental health first aid. And you can see at the bottom, use of force. Between 2014 and 2015, we had a 21% reduction in use of force. Now, I'm sure there's other things that took place in that, including the creation of CIT. But I know in Maryland, we were the first major department to train everyone. I've been told we were the first in the country to do it. This training is really important. Again, it lays the foundation of where we are today.
One of the things I'd like to say is we're one of the agencies where our chief has been supportive of my philosophy of not necessarily training every officer in CIT. I don't want this to be a checkbox. I think that's where police departments get it wrong. You train someone 5 years later, do they know what they're doing? If they're not working it and constantly in it, are those skills up to par? We need things to not be a checkbox, to be meaningful. And so by doing first aid, mental health first aid for every officer, you're able to teach them signs and symptoms that they can use out on the call to then radio for the next team that would be more appropriate for that call, whether it's mobile, whether it's our CIT team. Doing that across the board, and we're in service a lot doing updated trainings, but then getting the people who really want to be on those calls, getting them in to do the CIT training seems to be where we need to be. Volunteer instead of voluntold in a way is more important to make sure that right officer is on that call for service.
So as we move forward, you look at, we've created a culture of helping. Can you advance this? So it's creating a culture of helping. And think about this, when you look at the Disney model, number one customer service business in the world, they treat their employees the way they expect their employees to treat the public. We've created that culture of helping in which when a traumatic incident happens, the officers are calling a mobile team to help with the citizens in the community. At the same time, the officers know we're going to be there to help them. And it's sort of, how do you define a traumatic incident? You really can't. It's just, you know it when you see it. It's an incident that shocks the conscience. It's one in what our worlds collide for law enforcement. It could be that you respond to a SIDS baby death and you have a 1-year-old home. That happened to me. It's knowing, and how do we help? It's those incidents where the victims are vulnerable and innocent.
And so one of the things we've done is we've gone and offered CISM training, critical incident stress management, which pretty much every one of our clinicians in the crisis systems has, but also our officers. And one of the keys here is in the training is teaching those communication skills. So what I learned early on in teaching officers and working with them on scene is they want to fix a problem, right? So what we've worked on a lot between our mobile teams and our patrol officers is really teaching that active listening, reflective listening, not always trying to give the answer, but taking some time and letting the person you're working with. And so the same thing applies when we're doing peer support for our officers. We need to make sure that we're listening to them and making sure they're ready to go back to shift. So sometimes I think we forget that officers are human and that the calls for service they go on impact them. And it impacts that next call they go on. It impacts them that next day. So making sure after a call for service, our officers are ready to go on that next call and that they are able to have kind of a clear mind to make a good decision. And
it's adding to that is just like you don't want to ask someone, what's wrong with you? Well, what has happened to you? What have you experienced? We do the same for officers. You know, you take that 21-year-old happy-go-lucky kid comes out of the academy, and then he's turns into be a 45-year-old angry, mean, nasty person. Instead of saying, what's wrong with you? Well, what have you experienced? And that's, we recognize the effects that the trauma of the job have on the officers, and we address it at the moment that it happens.
In kind of creating this culture of helping is what we call it, we're working towards the relationship that we all have in crisis system, both with patrol and us. And what we're finding to be really effective is that officers like debriefing. with our clinicians, because they feel like those clinicians understand, because they're on those calls for service with them. And so a lot of times when we get together to do it, we are there to kind of walk them through that process for those traumatic events, to make sure that and really it's expected now. Our police department expects us to do those debriefings to make sure that our officers are well enough to go back on that call for go back out for call for service.
So as we talk about the CIT and our CIT unit, we have 141 officers in the department trained in CIT, and we follow the Memphis model with community collaboration among providers. It's a partnership with police department, family, consumer, partnership with NAMI, and of course our being integrated in crisis response. But the key is the people and the training that we have. It's the people with the desire to help and then having the right training.
And one of the keys is we didn't take mobile away. Mobile is still available for our patrol officers. We just added this unit in which we have our CIT officers paired with a clinician. And they're going on live calls, but most of their job is really to do that follow-up piece for those clients who are more dangerous, to make sure we're building that, that comfort level with police.
So with it, the training, at minimum, every officer has the Memphis model 40-hour CIT training when they're in the unit, 8 hours mental health first aid, 30 hours of critical incident stress management through the 30 hours of critical incident stress management through the International Critical Stress Foundation. It's giving officers who have the passion to help the training and tools necessary. And that combination, I mean, it's really extremely successful.
So this in patrol, we train officers. So one of the things is we're now expected as a CIT unit to self-deploy and respond to calls for service when we feel it's necessary. So if we're hearing things on the radio, our job is to help alleviate patrol as quickly as possible. So sometimes when there's a critical incident, we're automatically going out there and just standing by until they need us. We're always checking on them to make sure after the incident as well. Again, we got to get into this mindset of a culture to help. I think that's the key to things working.
So things that we respond to initially for the CIT unit, after a homicide, this Saturday night, there was a homicide in the county. We had a team there. Think of the victims that just watched this happen, how traumatic it is. We had a team there helping the victims, as well as to assist with the notification to the family of the deceased. Think how horrific that is for them. The next day, we had a team at the lineup doing a debriefing with the officers that responded. Again, how horrific it is for them. But also, we respond to barricades to help with the community, help with the families that are affected by that. And CISM, the critical and stress management, has become an instrument to our community policing. So, some of our referrals, diverting children from the criminal justice system. There's a 2% recidivism when there's children that have been charged with a crime. Their behavior is due to either exposed trauma where they've had numerous with cares preceding it, or you look back at their history and there's a mental health issue. Our job is to link them to appropriate community mental health services. We have, before the pandemic, we were meeting monthly with the state's attorney, the public defender's office, the school system, school services, alternative education, to help children that are already in the criminal justice system with that full wraparound services. I learned from an NAMI conference, an ACT team someplace else in the state had a client was stabilized inpatient, had numerous warrants for minor petty offenses. When they went into the judicial system, they were in jail. All the benefits that they gained from being inpatient were lost. We started when someone, and that happens with us, if there's criminal charges, the person is inpatient. Upon their release or discharge from the inpatient facility, we walk them through the criminal justice system. We work with the public defender's office. The client meets with our officer, the clinician comes up with, working with the inpatient facility, a long-term recovery for the person. To my knowledge, we've had no one in those circumstances recharged with a crime. We respond to threats, school threats, hospital diversion. Whenever a person is emergency petitioned by the county police, the city of Annapolis police, a hospital diversion clinician, one of Jen's clinicians, does follow-up. So there's times we get involved. We provide the police reports, so they have all the information. Safe stations. When anyone comes to a county police or fire station for help with addiction, we eliminate the barriers to get treatment. The criminal justice system is a huge barrier. If there's a warrant, they cannot get into treatment. There's people that think I quash the warrants, but we work in partnership with the state's attorney's office, the public defender's office, and the bench, and we work together to have the warrants recalled. We think how powerful it is when an officer is driving someone to treatment. It's us working together.
We're trying to move along quickly because I know we're running out of time, but just real quick, kind of to understand, our crisis system is pretty robust. We are broken down into 8 different units. I basically set the system up so that there are specialties depending on the type of call for follow-up. Follow-up is our key here. What we need to remember is that going out on a call, that one call doesn't fix the situation, right? Follow-up, 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 and making sure we don't forget to follow up. So again, we have our Safe Station program for substance use. We have follow-up for that. We have people who, our care coordinators, do the homeless piece. We get repeat 911 callers. That's our CIT team. School needs, that can be either mobile or CIT. But we deal with a large range of social situations. And so if I can leave you with nothing else today, it's great to go on that initial call. But if you're not doing follow-up and you're not linking someone to do that follow-up, then you can expect a repeat call for service, because navigating these systems are hard and people need assistance. And so follow-up is where we really pride ourselves in what we do here, whether it is our warm line 24/7 calling and just saying, hey, did you go to that appointment yesterday? Down to, hey, I know you were emergency petitioned yesterday and you were released home. Did you get an appointment? So we need to make sure that follow-up is done in order to get the proper care, because people get lost in that shuffle when we don't provide that follow-up care. And that's kind of what our system is all about.
And think about how powerful it is when the care coordinator is working with a police officer. The trained officer with passion to help is the one driving the person to that follow-up and is helping them at that time. One final training we talk about in the future, all our officers that are in service are going to be, I'm an instructor for the GAIN Center training on how being trauma-informed helps criminal justice center. That'll be in our recruit class with mental health first aid to all recruit class from now on, and eventually we're going to have it in our in-service. That's the next one.
Yeah.
It's great.
So if you need to contact us, there's our information.
Excuse me.
So thank you both so very much. This has been very helpful, and I made this required listening and watching for the committee on judicial proceedings. So we'll make sure this video is available, but we want to extend an invitation to everyone on this panel to come before the Judicial Proceedings Committee through Zoom to share some of this insight and knowledge, because this is fantastic, and I think this is the type of information that we need as we move forward into the next legislative session. Jen, the emphasis on the fact that training is perishable and that it has to be really in depth and it has to be renewed, has to be part of that culture. And then Steve, just the culture of helping and having that officer be the front line and the face, linking them to service, linking folks to services, that 2% recidivism rate, showing that the use of force statistics have gone down. And that's all things that we need to see in our committee, which would be really helpful as we move forward in our conversation about reform and reimagining the whole scope of services that we provide for criminal justice and intervention. So this has been fantastic, and I just thank you both for your service, because it's an important job, and I know you don't hear it enough. So thank you very much.
Thank you.
And for everyone on the panel, that concludes our presentation. Definitely, again, I want to just extend that invitation. I'll be in touch with you all to come before the Judicial Proceedings Committee if you're available and willing. I think our committee members really need to hear the information that you provided us. Next, we'll pivot off to a Q&A session. So if we have questions that are in the chat, we will pivot to those. And if not, then we've got a 15-minute break that I do not want to get in the way of for folks. So I'll look in the chat. And Nithin, if you help a brother out, if you see anything, you forward them off to me as well.
You got it, Senator.
All right.
It looks like for right now we're all set. Although if you want to submit written questions, please feel free to email us. I'll put our email in the chat box. You can also drop your questions in the chat box, and we'll try to do our best to compile them for everyone after the event. But in the meantime, I think we're all right to pass it along to Senator Hester, seeing as we have no question.
Well, thanks again. Thank you all very much.
Thank you so much, Senator Smith. Really appreciate you and all the panelists. That was a great overview. I think that we are going to take a 5-minute break. Is that correct, Dan? And come back at 11:10?
We can, we can, to make up some time, I think maybe 5 minutes is good to do, yeah.
Yeah, just a short 5-minute break instead of 15, and we'll reconvene at 11:10. And just to tee up the next conversation, we will be talking about Intercept 2 and 3. And this will be moderated by Secretary Green. And we're very grateful to have him up next. And on the panel will be Judge George Littman, a retired associate judge for the District Court of Maryland, Robert Weisengoff, Director of Public Safety and Correctional Services, and Alicia Salisbury, trauma specialist from Maryland's TAMAR program. So it's going to be an awesome panel. We'll give everybody 5 minutes and start promptly at 11:10.
Hello, Dan. It's very nice to see you again.
Who am I speaking to?
This is Robert Green.
Robert, how are you?
Good. It's been a while, my friend.
Way too long. I was looking for your name on the when we were planning this, and I was hoping you'd get involved one way or another. So
very much so. Thank you for being here, and hopefully we'll have a chance to catch up.
Me too.
So I think we're supposed to reconnect. Senator Hester, we're at.
Yes, it looks like that was the fastest 5 minutes in history. People are coming back to their chairs, so we are ready to get started, I think.
Okay. All right. Hi, I'm Dr. Linda Beneski. I am Senator Hester's co-chair for the Public Safety and Justice Subcommittee. I'd like to, we're going to review Intercept 2 and 3, and I'd like to introduce Secretary Robert Green from the Department of Public Safety and Correctional Services. He's also my boss. So we have Judge Littman, who's a retired district court judge and had run the mental health court for Baltimore City. Bob Weisengoff is unable to join us, so Secretary Green has agreed to review the pretrial services, and Alicia Salisbury, the trauma specialist from Maryland's TAMAR program. So Secretary Green, I'll turn it over to you.
Well, good afternoon, or good morning still. It's good to see you all. And as noted, this is our session on Intercepts 2 and 3. Intercept 2 being the initial detention and initial court hearings, and Intercept 3, jails and courts. And I must tell you, it will be very difficult for me to remain a moderator and not an influencer. I have been involved with this for a very long time. My familiarity with Dan Abreu, the Sequential Intercept Model, SAMHSA, and the Gaines Center, I would tell everyone on this call, was a highlight of my career over many years, and working with Dr. Hank Stedman, who I consider a mentor to me in this work, the study of mental and behavioral health. So again, I have been very pleased to see how this has evolved over the years since its initiation, and am as pleased and honored to be able to be a moderator for today's piece on these two intercepts. That being said, I think we've got a great panel, a great deal of information to share, taking that which hopefully all of you have been with us from the beginning, looking at what we were doing on the law enforcement side of the house, and now we're talking about this intercept at arrest and bringing before a judicial officer of the court. We've talked about the diversion and in my mind, the deflection piece, deflecting individuals before they come into our systems. So I've listened to that with great interest. I would also say that quite frankly, about our panel, I have worked with Judge Littman for a significant period of time on this. He is his input credible, as has been his work. And again, very fortunate to have known Ms. Salisbury for a very long time, back to her days around the TAMAR program and trauma work. In my previous life, I have the honor of not only running a prison system for the state of Maryland, but also a local jail system in Baltimore City. So a direct impact on us and how we do our work. That all being said, again, I think I would like to move directly to the Honorable Judge George Littman for his presentation and thoughts around this topic.
Well, thank you, Secretary Green. I hope I have my, there it is. I have the most homemade PowerPoint here, I think, of anybody on the program, because when Senator Hester asked me if I wanted to do this, I sort of went to the idea of, well, let me look at all the stuff from Sampson, Gaines, and all the outlines from the past. And Secretary Green and I worked on a few outlines over the years. And I said, no, what I want to do is I want to try to make some sense about where we are after I've been retired for a couple of years, and what sense have we made in terms of the mental health courts and all the other courts, and in terms of how does it relate to the real Intercept number 2 that I think is hot right now, is a place where a lot of the action is. I really thank you, Senator Secretary Green, and I'm just so glad you're where you are, because Secretary Green has been an absolute champion of this, and we've gotten into a lot of trouble together over the years, and I greatly appreciate it in advocating for some of these issues. I was looking at basically the folks who are repeatedly coming into all our systems, particularly the criminal justice system, and particularly also the hospital systems. When thinking about this, I said that's the group that we really should talk about, I guess, at some point here. And I think that you have to not underestimate the significance of their needs and the possibility that they are going to continue on some level, often, unfortunately, to find themselves in the criminal justice system. Sometimes when talking about the mental health courts in Baltimore City, some of our critics of that court, and we've had a few over the years, have said, oh, it's just about nuisance crimes. Well, in response to that, we pull up our caseload, and what do we have? A lot of assaults. And I'm not saying that every assault needs to be criminalized. That's not my point. But I do think that many assaults, particularly on providers of services, will find a response from the police department, and then we have to deal with, in some circumstances, Intercept 2 and 3. So I am a little cautious in my old age here about thinking that it can be completely eliminated, the contact with the police or the contact with the criminal justice system. I think what we have to do, in some circumstances at least, is have a better opportunity there to deal with some of those circumstances. So in my second slide, if I can get to it here, there it is. Oh, I went one too far. There it is. I tried to talk about what I thought we had accomplished in the problem-solving courts over the last couple decades, and what were the key elements. These are mine, not anybody else's. So here we go. Again, I want to emphasize what Judge Morrissey said. I think we should be proud in the judiciary of having expanded the problem-solving court so dramatically in the last decade or so. I mean, I do remember when there was 1 or 2 courts in Baltimore City. Now, Judge Morrissey went through 30-some courts or whatever. We have expanded that, and that is a very good thing. More important than the courts themselves, I think, is that we do have a sense in most of the younger judges now, which I think is a wonderful thing, that they are in the problem-solving business, not in the criminal punishment business. And I think that's a huge accomplishment, and I think that's something that Judge Taylor certainly emphasized earlier on, and I think is very important. So let me talk about this slide. What I've done on the left is services, services, services. I'm going to say this. The problem-solving courts and the judge's pretrial release and the judge's probation is only as good as the services they're released to. It is not workable if you are releasing somebody to theoretical services that don't really exist. It is a recipe for failure. And I really call your attention to Ms. Williams' presentation in the last panel. I thought it was excellent, where she was talking about that point, I think, in a very eloquent way in terms of all of the services and multiple medical issues that present when you see some of the individuals. So it really is the availability and continuity of treatment, mental health, co-occurring trauma, the whole gambit. If you don't really address them, if you avoid them and ignore them, I don't think you're going to do that well. So words like wraparound services, housing, housing, housing. In Baltimore City, we recently had, with the federal consent decree, a review of gaps, a gaps analysis. What came out of it? Housing, housing, housing. If you don't have the shelter that you need at the point and the more permanent housing down the road for folks that are unable to return home or don't have a good living situation, you're buying into more problems down the road. Employment, behavioral health case management writ large. Again, I think excellent slide from the early presentation from Gaines, where they had the picture of Batman right on the money. There needs to be case management written large. And here's where Secretary Green and I got into a little trouble over the years, but I'm very proud of it. We pushed, in the General Assembly was certainly there, clear responsibility for the individualized treatment plan development. In the next slide, I'm going to move on to the competency statute briefly, but I think one of the best things the General Assembly did maybe 15, 20 years ago was mandate that the health department, when releasing somebody from a mental health facility, state hospital, that they had an aftercare plan that addressed all of the issues that you saw on those other slides. Put it in the statute and said, you shall address it. I think there needs to be responsibility here on who's developing the plan, and there has to be responsibility here on when the plan is modified. It's got to be an individualized treatment plan, at least in the mental health courts for sure. It can't be a cookie cutter thing. Everybody gets the same, textbook checklist. Doesn't work. As other speakers eloquently have said before me, it is something that needs to be individualized for the circumstances as they exist. You need mental hospitals when you need mental hospitals. We can't wish them away. When somebody needs hospitalization, not overusing it, but when the stabilization clinically clearly requires hospitalization, there has to be hospitalization. And again, there has to be facility on the court side or the probation agent side or the diversion program side to change the conditions as they are modified by the living circumstances. We can't have a dumb stay away order still in effect on some conditional release when that makes no sense. So the courts have to be available and the monitoring agents. Monitoring, again, with a sufficient level of expertise. One of the great developments, and Martha Danner's coming up, I think she's done a wonderful job at probation on this, of developing specialized agents and training the other agents so that they are focusing on the individualized treatment plans and the needs. You have to have, in the specialty court area, the broadest array of carrots and sticks. If you don't use all your playbook, you're not really using it as a mental health court or drug court or problem-solving court judge. Again, the specialized teams of judges, states attorneys, defense attorneys, coordinators for the specialty courts has been a great development. And again, we need to expand that now beyond the smaller specialized teams to the broader ones. Again, with the competency statute, which we'll touch in a second, but everywhere else along the way, deadlines have to be real. Evaluations have to be really done. Placement decisions have to be based on reality. And this is hard work by dedicated professionals. Again, I don't think there's any question that the more frequently the courts, when they're on a probation situation, whether in a specialty court or otherwise, have status conference and review hearings and see what's going on, it reinforces the good things that the, quote, defendant is doing. It reinforces the good things that the treatment program is doing. It reinforces the good things that the monitors, pretrial release, probation are doing. One concept that somehow gets missed sometimes in these analyses is that the bundling of cases is taking place. Rarely do these courts, specialty courts, mental health court, drug court, veterans court, felony drug initiative, work with only one case. They're often bringing cases in from other parts of that court system or other jurisdictions. In the mental health court in Baltimore City, we had many people on probation in Anne Arundel County, in Baltimore County, in Howard County, Harford County. Similarly, they had people from the city throughout my career on probation. The act of bundling the cases, consolidating the cases is important. And it also expands the sense of need. It's not just an individualized case that somebody's trying to dispose of. It's really much more holistic, and it's important. Briefly on the competency statute here. My only point here is to say, if it ain't broke, don't fix it. I think we have one of the best competency statutes in the country. I've been on a committee that's looked at them. I'm not changing our statute for anybody's. I think we've done an essential conceptual point here that's good. And that is we're coupling the restoration of competency with the stabilization of the individual to lead to a successful return to the community with real release conditions that might work. I think our statute really mandates that. I think it's great that way. Requiring prompt evaluations, prompt admissions to the hospitals, prompt return to court. We're not stabilizing people in jails or prisons. We're stabilizing them in hospitals. I think these are important public policy decisions that the General Assembly has made, and I think they made the right ones. The most important thing, again, is the competency statute requirement that the health department or facility prepare a sufficiently detailed and realistic continuity of care plan when the person returns to court. The court has a responsibility, and I think we're doing it even in the COVID times pretty well, not perfectly, but pretty well, to bring the individuals back to court. And if we can release the individuals to the community, we release them quickly with a plan that works. Some people can't be released to the community, right? Some people have serious charges and they're going to have to go to trial on the murder case. That does happen. Likewise, courts can be, I'll admit this, too enthusiastic at times in taking lesser cases and going through this when they should be just simply disposed of. But I think we can't ignore that we have in this middle area here a lot of cases where there is a sufficient need for mandated continuity of care, basically. Competency, of course, only applies to the most seriously mentally ill cases, folks that are so disabled that they can't appreciate the criminality of their conduct or work with their defense attorney. But I think it does inform on Intercepts 2 and 3. Okay, here's my main point, and I'll try to be brief. Now we are moving to Intercept 2. Certainly that's been accelerated by justice reinvestment, and I think the proper, again, congratulations to the legislature. I agree with you on the points that were made in justice reinvestment in terms of limiting the bail considerations to folks who are really dangerous. And I think as time goes on, it's become a stricter interpretation of how dangerous is dangerous to detain somebody in jail. And I think that's appropriate. It should be a strict definition of dangerousness. And of course, now we have COVID on top of it. So judges and everybody is thinking about, well, does this person really need to be exposed in the detention center? But with that in mind, let's look at the last slide. How do we get to a situation where we do enough continuity of care or put conditions on people's release so that it's meaningful? So we're not just releasing the person back to the community to fail. And we've got to remember the last piece of this slide, failures to appear exist. In other words, oftentimes when we put somebody on release, pretrial or otherwise, and they don't appear, then what are you going to do? Are you going to just let them slide on? Are you going to bring them back and hold them in detention for a little while for another go at it? Are you really going to say that we're going to stay here for a little while, no bail, and see where we're going? It's a tough decision. Judges have to make it every day. But I don't think panels and summits like this can avoid the thought of what happens with failure to appear. And often it's not the fault, if you will, of the defendant, but it's the nature of some of the co-occurring conditions that they're facing. Remember, original bail reviews happen quickly, 24 hours, 48 hours after the person's arrested. That means a lot of pressure on the people trying pretrial release and others who are trying to come together and give the judge a meaningful condition of release. So it's hard, but it has to be done. If you delegate it to the pretrial release agency, in other words, a judge just puts a stamp on there that says conditions of release is required by pretrial release, they still have to focus on all of that. Again, I think that one of the reasons, and I think it's great that Judge Taylor made that presentation up front, is I think that she and others are working diligently on trying to bring the problem-solving court model earlier into the system, earlier towards pretrial release, maybe 10 days, maybe 7 days. It's a beautiful diagram she's done. It's going to work, I think, from the judicial side and the partners, the public defender, state's attorney side. That'll work. The question is, will we have real and meaningful conditions of release available to us, at that point in time? I was, at this point, Mr. Secretary, I was going to try to set up my good buddy Bob Weisengoff for saying, hey, Bob, what the hell are you doing about all this? But now I don't think I'm in a position to do that. But, I don't care. I'll just spot you with it, Secretary. How are we going to create a pretrial release situation that's going to be meaningful at 2?
Thank you, Judge Littman, and that's a great setup. My apologies on behalf of Bob Weisenkoff, but hopefully I will do a meaningful job filling in here.
I'm sure you will. I'm sure you will.
So I'm going to talk briefly about pretrial. We do not have the benefit of Mr. Weisenkoff's slides, but I think we'll be okay. And I'll start by saying, so now as we enter this intercept of, we've placed deflection. The deflection opportunity is to a degree behind us with law enforcement, and we're coming into our systems. And in many places across our state, you're coming into that system via a central booking unit or a central processing unit. And how does pretrial set up to work with those types of situations to be, and you'll hear me use the word frequently, nimble. And nimble is, it applies to what Judge Littman said and how we are able to engage and get these beds we need. But nimble also applies very, very heavily to the pretrial release program. So we're all on the same page. Pretrial operates in a majority of the counties in the state of Maryland to some degree. Pretrial is a very local program. It should be focused on connection to many of the local services that you've already heard about. We have statewide services and local jurisdictional services as well. My history with pretrial is I've run pretrial services in my 36 years in corrections in 2 counties in which I worked for, and most recently 18 years of my life in Montgomery County. An incredibly robust pretrial release program today. In my current position, I'm fortunate to work with Bob Weisenkoff, Director of Pretrial Services for the Department of Public Safety and Correctional Services and our Baltimore Detention Center complex. Pretrial for us at DPSCS, it's one of the oldest programs in the country. Our pretrial program was founded in 1966. And if we understand the focus of pretrial release, as I believe building on what Judge Littman said, pretrial release is our next piece of community supervision. It is the ability to monitor an individual, set perhaps some level of community connection and supervision for an individual to avoid incarceration. At the beginning of the pandemic in our system, we had 891 individuals. We are supervising in Baltimore City, 2,362 individuals as of yesterday. And that is with a failure to appear rate of 3%. And a rearrest or criminogenic behavior under supervision of 2%. Those are good numbers. I would tell you in my previous life, where Senator Smith is associated, Montgomery County had a very robust pre-release program. And I truly believe across our state, we need not reinvent the wheel. To take Judge Littman's statement, we need not look other places. We have some incredible examples of programs that are operating. I echo what Judge Littman said around, I remember when the courts only had a few problem-solving courts. We've evolved, as has our pre-release programs around the country, around the state rather, with our local partners. I think about pre-release, and we don't look at pre-release as just an opportunity for community supervision. One of the interesting pieces of pre-release is that assessment, that validation of need, that contact with the community that is already has an association. We've already made a connection in the community to a program, and how do we in a nimble fashion be able to present to the judiciary during the bail review phase, the initial appearance phase of what connections we've been able to establish, validate, and get an individual into the programming that we've already spent a great deal of money, taxpayers' dollars, and focus on getting an individual connected to, and also identifying those that need that connection to a community program. But the ability to be nimble in doing that. with the courts. The ability to be able to make those recommendations to our judges is extremely important. I would note another factor around pre-release that I think is extremely important. I think we often focus on this perhaps the supervision component and accountability component, but there's a great deal more to that. We did an assessment in my previous life of how many of the phone calls, while we would initiate a phone call as a supervising agency, as a resource, it was amazing the number of inquiries that are initiated back. Phone calls that you receive in a day into a pretrial release program, 30, 40, 50% that are initiated by the client, the individual seeking the service, and the ability for pretrial programs to be fully integrated into what communities have available to them to be the resource back. It's not always that phone call. How are you doing? Are you where you're supposed to be? Are you gainfully employed? What can we do to assist you? But that individual engaging the opposite way. All right, I have a crisis. Can you help me before this crisis turns in to a potential criminal justice interaction? I need service. I have an appointment. I have a court date with Judge Littman coming up. And by the way, I need assistance in getting there. For me, watching the evolution of pretrial become the connector for individuals is critical. That's why you get to the FTA rates that we're talking about. That's why you're helping get people to the point that they need to get to. You're using those local resources, you're navigating them, you're connecting and becoming a really valuable resource in helping an individual stay stable in the community. Because we've made an investigation through a validated tool that the individual need not be incarcerated. So how do we stay connected? I say the pretrial release programs across our state are critical to this conversation at this intercept. What is available to them, what services they understand, capacity to be able to manage individuals in the community, and not just have it be a phone call, but have it be a very interactive service to make a difference. So I think that is my infomercial, if you will, and my influencer portion around pretrial release programs. I do not want to take up everyone's time. I think we're going to have a great deal of conversation. Hopefully we'll have a great deal of questions at the end of our session. I want to move to our next presenter, if I may. Miss Alicia Salisbury, we have her here as the trauma specialist in Maryland's TAMAR program. I was fortunate to be involved in this system when TAMAR began. It is an amazing program with amazing people that had started it, and I am pleased to introduce Alicia Salisbury. We don't have you on screen yet, Alicia. Do we have Alicia?
Yes, I'm here.
All right, very good. We have you. We can hear you. We can't see you. Is that your intent?
I'm trying. Yeah, I was trying to get that. How's that?
We can see you. We can see you fine.
Very good. We have you now? Okay.
Oh, hi. For the sake of time, I know everybody, we're getting close to lunch. I'm going to do without the slides. So I just wanted to say it was great to be introduced by Secretary Green. As he alluded to, we worked together a lifetime ago, it seems, 21 years ago, actually. And there's some important work that came to be as a result of our collaboration and working together. So in 1998, the it was actually the Department of Health and Mental Hygiene, which is now Behavioral Health Administration, and their Division of Special Populations, along with University of Maryland's Department of Psychiatry, was looking at gender-specific programs. They wanted to know why specifically the female population of those involved in the criminal justice system and those that were incarcerated was so high. So 3 folks were hired. I was one, and SAMHSA had a 3-year agreement to do a pilot program to hire 3 clinicians to find out a little bit about maybe some of the answers to that big question. And 21 and a half years ago, that has become my most passionate work, most valuable, meaningful. I've been an outpatient provider on the Midshore of Maryland for about 30 years, and I've been doing this work for 21. And it's been a great teaching opportunity. It's been a great collaborative effort, being able to work with law enforcement officers doing CIT, critical incident stress debriefings, and just educating about trauma. It's also helped me to be able to collaborate with the National Center for Trauma-Informed Care, doing trainings around the country where we can share the knowledge of what we're learning and what we learned back in Maryland. So that being said, and being cognizant of time, so back in 1999, when I was hired, I started on the Midshore of Maryland and local rural detention centers on the Midshore. And what I found in talking with a lot of the women was it wasn't what their charges were per se. A lot of them had substance abuse, DUIs, violation of probation, because their coping mechanisms were just all that they knew were perhaps, I hate to use the word maladaptive, but they did not allow them to live their best life. And they were basically doing all that they knew to do. And but that wasn't working, hence why they're involved in the criminal justice system. So what happened was, in talking with them, and I would say probably 90% of all the women that I've spoken to and do an assessment for the TAMR program, which stands for Trauma, Addiction, Mental Health, and Recovery, that many of them, those that feel safe enough, because you have to start where you feel safe. Without safety and trust, there is no work. So, and that's with everyone with trauma. And so what we later found out was that in being able to do a lot of those interviews with the ladies, that they were saying that, yes, I'm in here, I'm attending substance abuse programs, I've been involved perhaps with AA or NA, but it's not working, and I don't know how to get out of this cycle. So that's where trauma came into play. That's where we learned about it's important to ask what's happened to you. And that's that big question right there. If you take nothing else today, if you can take that away, it's very important to ask. Just as we know with law enforcement, being able to do crisis intervention, critical incident stress debriefings, all of that. We are human beings. So when I started in the correctional facilities, what I found was I'm still a guest in the facilities. I'm not a correctional officer, but we are serving the same folks. And we want to have a win-win opportunity for them when they are released to be able to have that continuity of treatment and be able to work together. So when I first started, it was interesting because I came from an outpatient practice, and I'm the social work clinician coming in, and I found that it was really difficult. We had to learn to respect each other's roles. I had to learn about contraband when I brought in coffee for my groups, and just a lot of collaborative efforts that took place. And so monthly, what we do is we get together locally on the Midshore. It's judges, so it's the judicial system. We have senators that attend these meetings. substance abuse, mental health, parole, and probation. And we make it important. It's now every other month through Zoom, but we get together, and the warden that initially was very progressive in the county where I started, had the vision. He actually was the host of getting us all together and collaborating. And we get together and we problem solve, and we try to work together for the so that the person can live their best life on the outside. So one of the things, key components I learned was the lingo that we all use despite our disciplines. So it might be consumer, client, patient, inmate, and we're all talking about working with people. So it's important to remember that despite all of the jargon that each one of us has that's specific to our discipline. So groups meet. We have, when a person comes in through the Sally Port at the local detention centers, they come in, they are classified after a few days, perhaps not right away. Some of them may have to detox. They're given an inmate handbook. They're seen by a doctor, a psychiatrist. We have mental health providers, case management, which is the glue. And then they're given an inmate handbook, and they're given Dr. Vincent Folletti's ACE 10-question questionnaire, which isn't meant to be, and he never intended it to be, like a PTSD diagnostic tool. It's kind of a baseline. Again, what happened to you in your life that may be why you're here today. Ineffective coping skills. Let's trade some of those coping skills that drinking may have helped. The drugs, crack cocaine may have helped numb the pain, but it's not enabling the person to live their best life, and just working together to be able to do that. So they're given, each inmate, person that comes in on the female side, they are given the questionnaires, they're given information that's then put in my mailbox, and then I'm able to do a clinical assessment and do some trauma assessment with them, if you will. For many, I would say 90% of those that feel safe enough to even talk about their history, they will share that they have had a history of significant events. And again, it is so important to say, those are the ones that feel safe enough. Again, many are very guarded. And so there's secrecy, there's shame, there's trust issues. So what, in a nutshell, what we've learned, trauma, if not at all addressed, we can't change what we're not aware of. If that's left untreated, a person feels hopeless, helpless, scared. No one wants to feel that way, right? That then leads to compulsions and feeling empowered, perhaps self-medicating, addictions, dependencies. And then that leads to being engaged in illegal activity, and how we get a chance to perhaps meet a lot of these folks. And then this puts a person at risk for being arrested again, jail time, psychiatric inpatient hospitalizations, and then the cycle goes on if not treated. So I'm hoping that checking the time, I'm hoping in the next couple of days, if there's any questions, we can talk a little bit more about that. But it's just been very meaningful work. And I have to also say, we do have continuity of treatment, and we recognize that. We have to educate the officers. We have to work together. We're a team. We have to be a team. It was easy when I first started to have this, you have initials after your name, you have an outpatient practice, I'm safety and security. Yes, you are. But if an officer is hurt, and an officer might re-traumatize someone just by doing their job, the officer's hurt, the inmate is hurt, and no one wins in this situation. So it is important, and there have been over the years so many meaningful stories just among the officers that I've spoken with and been able to observe their awareness. Again, you can't change what you're not aware of, and also in just working with the people that I serve inside the criminal justice system walls, if you will. So again, I guess I will end with this. One of my favorite analogies is we tend to be very reactive. I'm talking to the choir here. We tend to be a reactive society instead of preventive. And one of an analogy I heard years ago that has really stuck with me and I tend to use is when someone said, you know, it's far easier or we don't have money to spend installing seatbelts in all of these cars and trucks because, you know, we're too busy stitching up foreheads over here. So lives could be better served when there is increased awareness and we can address trauma, and that goes across the systems that we work with as well.
Thank you very much, Alicia, for your work and quite frankly, being involved in the evolution of this. Alicia's work ties us directly into Intercept 3, jails and courts, the individual that has been committed to the custody of our local detention centers. You know, we're talking pretrial now, or committed to a term of confinement within our state up to 18 months. Alicia's program that she described is one of many. And now I'll perhaps give you the 2 to 3 minute infomercial, because we could do a day on what we are doing and perhaps what we should be doing within our local jails, having been there and been involved in that system and now running a large one myself. But the connection to these programs, we should have individuals, if the courts determine that they are to be housed within our facilities, what do we do while we're there? What programs do we have? The opportunity for licensed clinical treatment, true behavioral health change, substance abuse treatment. You know, we can't accept, and I know I'm preaching to the choir here, that while NA and AA is a wonderful supportive structure inside a facility, we need licensed clinical treatment for individuals to take full advantage of that. In the evolution of my work of 36 years, I will tell you that what we've done is what we've learned is, one, we need to have those programs available in the community, but we must sustain the connection. Alicia used that term, the continuity within the facility and continuity of care as we transition people home. We can build wonderful programs inside the institution, but they must be sustainable and connected. It's like building a support structure for someone and not having the ability to support them outside once they leave. That has been a strong message for me as a manager of a local jail and now a prison system. So again, I thank Alicia for that. I thank you for your work and how that has evolved. I would tell everyone on this call that there is a wealth of programming that exists inside our local jails that we should take note of. We should take note of then what is the consistent measures that are working. What does the science tell us is most important and progressive for the period of time that we have individuals? But it should never be the excuse that we don't have time. Open enrollment, the ability, this was something in my life that we experienced, and then I'll shut up, which is very difficult for me. That you have programs that you begin on a certain time and you end on a certain time. Well, we don't begin that to the first of the month. No. We need open enrollment. We need open opportunity for people to enter where we find them. And again, to be nimble in our programming of what we're going to do and what's going to come of these conversations. But there are people on this call that have helped us do this in the state. Alicia, Dr. Littman, Judge Littman, Dan Abreu. So we have wonderful models. I'm looking forward to continuing this conversation, but would love to leave this open also for a few questions as we see people drop off as they become hungry. So I want to make sure we're covering the questions. There was one question that was thrown out around some of the beds in the community that supported transition and population. They're suffering economically as we go through this issue of court shutdowns and the pandemic. I think I would say to that we are in extraordinary times, ladies and gentlemen, and many facilities are not able to appropriately social distance treatment centers and other providers. And yes, we're going to have a new world as we come out of the backside of this. But first and foremost, we've got to concentrate on keeping people safe, and the balance between how we do that. We are able, as a system, we're still transitioning people to programs that are open, but that support for those programs is a reality. And we have seen 1 in 3 or 4 or 5 that just don't exist anymore, which will create more challenges for us as a system, looking at a new reality, both economically, budgetarily, but it doesn't make those suffering with mental illness and those in need of treatment any less worthy of our time. We must be creative in the solutions we find. A colleague once told me, and I quote him frequently, there is not often an equation between how much money we can place on and fix it. Conversations like this will assist us. Other questions? I'm not seeing many pop up on the chat, but I want to make sure that I am being cognizant of making sure we answer everyone. And if anyone wants to pop on and ask a question. Let me make sure.
Thank you, Secretary Green. I just want to check with my chief of staff and the technical folks. Have there been any other questions that have come in for Secretary Green or the others on this great panel?
From what I can see, it looks like you've done such an extraordinary job that there are no questions. It looks like you've covered all your bases.
The fact, but I think probably a bit of a hunger setting in for the day. Senator Hester, I want to thank you. I want to thank the leadership, the Lieutenant Governor for his support of this, and the opportunity to spend an hour with such esteemed colleagues and those that are interested in this work. Thank you.
Thank you so much, Secretary Green. And certainly it's the start of a conversation. With that, I think we're going to move straight into our last panel of the day, pushing on through to intercepts 4 and 5. This next session will be moderated by Martha Danner. And Martha Danner is the Director of Probation and Parole of the Maryland Department of Public Safety and Correctional Services, where she oversees a staff of about 1,000 in 41 offices around the state. Director Danner also serves on the Board of Trustees for Maryland for the Middle Atlantic States Correctional Association, and as Maryland's Commissioner for the Interstate Commission for Adult Offender Supervision. On the panel, we'll also be joined by Mary Ann Thompson, Deputy Warden in St. Mary's County Detention and Rehabilitation Center, Scott Sheldon, the Certified Peer Recovery Support Specialist for Howard County. Hello, Scott. And Patricia Towns, Assessment Supervisor, Maryland Division of Parole and Probation. So with that, I will turn it over to Director Danner.
Thank you, Senator Hester. It is an honor and a privilege to be a participant in this summit on behavioral health and the justice system. I'm honored to see my colleagues and my co-workers from around the state. I'm honored to see Chief Judge Morrissey and Judge Taylor, and I'm honored by Lieutenant Governor Rutherford hosting this. I would like to say for the Division of Parole and Probation, we supervise over 45,000 individuals throughout the state of Maryland, and we are very involved in public safety, but also in being change agents as we work with our clients to have better outcomes for them. We have over 287 vetted community partners that we utilize as our resources to assist. And the vetting is completed by the department's community resource engagement team headed up by Terry Ricks, which I am sure many of you are familiar with her. It is great to be on the Intercept panels for reentry and community supervision, and I am honored to have Deputy Warden Mary Ann Thompson from the St. Mary's County Detention Center, Scott Sheldon a peer certified recovery specialist that is so important as we work with our clients, and Patricia Towns, who is from the Division of Parole and Probation that runs our assessment and placement unit in Baltimore City. So with that, I will turn this over to Deputy Warden Thompson. Ms. Thompson, you may be muted. Ms. Thompson, I think you're still muted.
I think she's having difficulty because she is unmuted on the screen.
Perhaps we could go on to Scott Sheldon or Patricia Towns, and we can try to work through the technical difficulties with Ms. Thompson offline.
Absolutely. Next, we will welcome Scott Sheldon, who is a certified peer recovery specialist for the Howard County Health Department. As we all know, peer support is such a value to help our clients get on the right track. And Scott, are you ready?
Sorry. Yeah, I'm ready. Can everyone hear me all right?
Yes, thank you.
Sure. And I'm trying to gain control. I guess I don't have control of these. Oh, I do. All right. My name is Scott Sheldon. I am a peer recovery specialist for the Howard County Health Department, as well as for the Howard County Department of Corrections. I guess I'm not sure everyone is aware of what a peer specialist is, but a peer specialist is a person with lived experience who's been trained to support those who are facing similar struggles and barriers. The peer's personal experience provides them an expertise that classes and training cannot duplicate, and this experience allows the peer to relate and connect with the people that they're trying to motivate and support in their process. I know for myself, to kind of disclose my personal experience, my lived experience, I have been incarcerated in more than 14 different institutions. Most of my charges pretty much directly correlating with my substance use disorder. In that time, you know, like I would get involved while I was in there, and then do whatever programming was available. This was typical for me, and it was kind of just, I didn't see what was actually going to change when I got out, because there was no support that continued on, and when I got out, it would be overwhelming, as was mentioned in one of the earlier panels about all the pieces trying to put it all back together. This, God willing, this last time that I was incarcerated was over 5 years ago that I went into the Howard County Detention Center. And God willing, that's the last time I ever go into a detention center as an inmate. And the peers that I met in there through the Howard County Health Department really opened me up to possibilities that I had long believed impossible. I got into trouble very young and started using very young, and the problems that I created for myself, I believe, defined my options and my future. And that belief was what locked me into that cycle of self-destruction over and over again, because I didn't believe it was possible to get out of it. I believed it was too late, that I'd already messed up too much. And meeting those peers kind of opened me up to the idea that it's, that change is possible. And that made more of a difference to me than any of the other programming, all the information that I'd gained and absorbed. Because it doesn't necessarily matter what you know, it matters what you believe and what you do with that belief. And my belief that I couldn't change took precedence over the knowledge of, like the treatment and 12-step and the things of that sort. And so honestly, being incarcerated at the Howard County Detention Center had more of an impact on my life than probably anything else that I can think of. Initially coming in, I had to go through detox, and I eventually got assessed and was able to attend the health department's addictions groups in the detention center and met peer staff there. When I got out, I went to a treatment program called the Howard House, and from there continued to meet more peers who were working out of other programs that the health department was connected with, such as On Our Own of Howard County. And since then, the peer role has evolved, and the detention center has picked up its own peer staff. The health department still puts its peers into the detention center connected through the addictions programs. But that, that along with the multitude of programs that are available there often require either time being spent, certain conditions being met, and, continued involvement in their time there. Whereas some people come into the detention center for days, maybe a week or two, a month at the most, and it's easy for those people to kind of get lost in the process. I myself have experience with overdose after a short incarceration, getting out, relapsing, and overdosing. Thankfully, somebody was there to call 911, and they revived me with Narcan. So now, with the peers hired by the detention center, we're able to do an initial screening. So all of the staff, the intake officers, the medical, a number of the staff there are trained in motivational interviewing. And so upon intake, immediately, the new detainees are being pre-screened with SBIRT protocol, screening, brief intervention, and referral to treatment. So that pre-screening lets us know if someone has any indication of a substance use disorder. Even if that doesn't, we can also look at their charges, their charging history, and their urinalysis, which is a standard for everyone coming in. So between all that, we can determine if somebody has any indication or history of substance use disorder and make an immediate referral to the peer staff. And the peer staff that is working out of the detention center will prioritize people based on if they're going to be short-term, if they are detoxing, if they talk about bailing out, so that way we can get a conversation going before they go back out the door. And that conversation can make all the difference. Now that the detention center provides MAT, such as Suboxone, methadone, and Vivitrol, there are a lot more options to kind of start the recovery process without having to just fight through that part first. A lot of people coming in, if they're detoxing or they don't have MAT accessibility, make it so that it's a lot harder to start considering what other options there are when you're dealing with that struggle first. Sorry, I'm kind of all over the place. My slides got a little mixed up. So my lived experience includes behavioral problems as a youth. I was a high school dropout. I have bipolar diagnosis, my numerous incarcerations, and a couple overdose survivals of my own, and a number of friends of mine that have died of an overdose. And often that is due to a lack of communication and a lack of access to resources that might have given options to help prevent that. And over time, those resources have grown, and access to those resources has become more prevalent. So the peer roles within the detention center are not just to perform an SBIRT, but they also educate them on the MAT options that they have, on the different levels of treatment that there are within the detention center and upon exiting. If they're going to participate in any treatment while in the detention center, what their options are as far as recovery housing on the way out, or residential IOP programs. We provide Narcan training to nearly every inmate in the detention center with the availability of their own Narcan to take with them on the way out. Even if they don't necessarily indicate SUD themselves, a number of them have friends or family that do, and we try and make sure that everyone has a training and understanding of Narcan and has the option to take that with them when they leave. So initially, the detention center was only using the health department peers, and health department peers were initially only in the addictions programs. And then we began doing GIPRAs and SBIRTs with the new detainees, and that started taking up a lot more time and need. There was a lot of need for that, so the detention center decided to hire its own peer staff in order to have them in there pretty much as possible. So I'm trying to focus on the detention center peer roles, but in Howard County in the last 5 years, the role of the peers has increased from just being connected with the health department to then also working out of on our own of Howard County, working directly with the hospital to talk to anyone who has come in with a substance use disorder or overdose survival. We have a public peer phone line, both for the detention center peers and for the health department peers, so that anyone who connects with them that wants to reach back out has the ability to do so. We oftentimes, the peers are, because they can relate and connect and have had to utilize the same resources, it makes it a lot easier for that person to talk to them about their needs. When everything is clinical and administrative, often people don't want to maintain that contact or maintain that connection. And so I believe that the peer connection is vital to continue the connection of these resources throughout the community. The reentry program at the detention center of Howard County has done amazing things with connecting people with resources, but oftentimes just to find out about it or to maintain that connection, it requires a peer involvement to help that person embrace that and not feel like they're working with jail staff, because often a lot of people coming through the jail have no interest in maintaining connection with that jail upon exit. And so we try and keep that separate, keep that interaction separate from the feeling of working with the jail staff. The peers have their own incarceration experience, their own substance use experience, their own mental health experience. We now have a harm reduction SSP program in the health department parking lot with peer staff on site. And the peers working in the detention center often are connecting with people who aren't necessarily interested in immediately going to treatment. And so now there's a community resource for them to help refer them to besides MAT, there's also the harm reduction services, the SSP program, in order to help diminish the overdose likelihood if somebody gets out and uses. Often people come in there for only a couple days and they have no intention of stopping their use. Our peers there, both with the health department and the detention center, if they get an opportunity to have that conversation with them, help inform them and make them more aware of what their options are wherever they're at. Like the expert process and the peer role isn't necessarily to convince somebody of something as much so as help them recognize what goals they have and how they can best get to them. And often that starts with harm reduction, that starts with MAT, and then that starts with staying connected. And so the peers do their best to have one-on-one conversations wherever possible, to let them know their own personal experience briefly in order to know that it's coming from someone who understands and relates and not just from someone who is educated about it. The health department's peers co-facilitate the addictions groups with the clinic, with the clinical counselor, the licensed counselor, I'm sorry. And so that way we have perspective from both sides. Let's think what else I'm missing. 15 minutes goes by really fast. Give me 1 second, I'm sorry. Great. My notes are not responding.
That's okay. We did have one question for you, Scott.
Okay.
Peer eligibility. How do you become a peer recovery support specialist?
Okay. So for myself, initially, I was utilizing the resources of the reentry program out of Howard County. In utilizing those resources, I was also asked if I could help others, because at that time the jail and the reentry program did not have a peer staff, and the health department peers were specifically connected with their program. So I was helping people with their smartphones. I was helping people understand the bus routes. I was helping people understand how to set up emails and make resumes. And so then the detention center created a peer position and asked that I apply for it. And I got that position. And from there, I would see the health department staff that helped me in the same detention center that I had recently been incarcerated. And so they saw me speaking to other inmates about transitioning, about staying out of trouble, about making the right choices. And a position opened up at the health department, and I applied for that and was able to get that role. Pretty much anyone who has experience dealing with substance use disorder, dealing with mental health issues, dealing with incarceration and criminal history, who is now making better choices and moving in the right direction, has the ability to apply for the peer position if they see one available. Different organizations have different requirements of recovery, of activity and involvement in community programs or understanding of community programs. So that's kind of unique to each organization. Sometimes they expect you to have been in recovery for as little as 6 months to a year. Others want 2 to 3 years. And but with all the different programs, there's currently the health department and the detention center peers work within the detention center with the returning citizens, outside the health department with the harm reduction, in the hospital, on our own, with workforce development, and the grassroots has its own peer, which is they run the shelter in Howard County, and our peers and the grassroots peers work with the Leola Dorsey Day Resource Center, which is for resource center for the homeless population. So the peer involvement has grown immensely in the last 5 years here in Howard County, and we try to connect with any program and any opportunity to make peers available, and that coupled with a public phone line that anyone can call to talk to a peer pretty much any time during the week. we're not necessarily expected to answer after work hours, but it's 24 hours from Friday to Monday. And if they leave a voicemail or a text message, our peers will get back, and often they answer the phone anyway, even when it's after hours, because we don't want to miss the opportunity to help somebody or give somebody the information they need. When I applied for my job at the health department as a peer, I've been working flipping burgers and had just started supporting the reentry program just by letting other people know about resources. But my work history was quite sporadic. My qualifications seemed to be my criminal history, my drug history, and my leaving that behind. So it didn't require a lot of convincing. Like the interview process was quite different than other jobs that I've applied for. So I don't know if that answered the question.
I think it did. Yes, okay. Absolutely.
Are you able to help people in jail adhere to their medications? So while they're in the detention center, if they are on MAT, they adhere pretty regularly. Like that's it, having them adhere to it and maintain it. Our detention center has really good protocols for making sure that there's no smuggling, saving it to take extra doses or any of that. So most of the inmates that are on MAT in the detention center or on any psych meds deal with a medical staff and administrative staff that are very involved in that process and very aware of motivations to manipulate it and do their best to prevent it. And the peers do have conversations regarding those medications and the reasonability of it, because often people on MAT might still intend to use on top of it when they get out, or stop the MAT when they leave so that they can go back to illicit use. So those conversations do happen, but the peer coordination and the peer support and the peer programming through the health department and the detention center don't necessarily have anything to do with monitoring adherence, but more about the conversation of setting goals and what makes sense to reach those goals. Because everyone in the detention center will say, I'm not coming back. But 90% of the people in there have been there before and said the same thing before. And so if their goal is to not come back, then it's important to discuss that, like maintaining your medication, whether it's a psych med or an MAT, and utilizing that for the purpose of being able to make better choices, being able to maintain employment, being able to find stable housing. Having those conversations on the correlations of those things is what comes out clearer than just administering them and hoping that it makes sense. In my experience, being able to relate to everything falling apart as soon as I leave and everything that's out there but not knowing how to access it has made a huge impact on quite a number of people that used to regularly come through our detention center, that used to be regulars on the overdose list. And so I find that peer involvement at every level seems to make a huge impact on people that were for a long time believed to be kind of a lost cause.
Scott, is there anything else you would like to add or present on?
Well, let's see. I guess if there's time at all, I feel like I've used up all my time. So my role has gone from being just a person helping other people get out to a peer specialist trained and certified to a peer supervisor who still maintains the connection with the people that we're trying to support, but also helping coordinate programs through multiple agencies across the county, because everyone is seeing the impact that the peers have had. When you have a conversation with not just myself, but others like myself who have worked directly with peers throughout the entire process, I think you'll find that that often resonates more than many of the other aspects. I know for myself that peer involvement helped convince me of the change that for many years I believed impossible, despite all the programming, despite all the clinical support, despite the MAT that I had utilized. The peer involvement made a huge impact on myself because it showed me proof to my face that it wasn't too late to change. There were people older than me that had started later. There were people who had worse history than myself who were doing well. And, it didn't require me to learn anything. It didn't require me to necessarily initially do anything, but that change, that belief in that change that a peer represented to me gave me the motivation to ask for help, to take direction, and to kind of follow a different path for once. Because without that belief, all the programs and all the support out there isn't going to have any impact at all. That the individual needs to believe that the change is possible, or else they're just going through the motions until they go right back to what they know.
All right, thank you very much. And congratulations on your new path, your new career path, and on your sobriety, and for educating us practitioners on how to improve services. I really appreciate it. Next, let's move to Deputy Warden Thompson from the St. Mary's County Detention Center.
Hi, Ms. Thompson. It seems like your mic is still not. Matt, could you hop in and see if anything's working there?
Now can you hear me?
Yes.
There we go.
Okay, very good. Very good. So just to, I apologize for the technical difficulties. So for many inmates, their path to incarceration started in childhood and was marked by trauma and poverty. Evidence suggests that the better engagement and treatment for persons with mental illness or on reentry does reduce the risk of committing a serious crime. Substance abuse disorders, both drugs and alcohol, are a huge concern for inmates in the detention center. As a result, many who are released, although have detox, return to opioid and alcohol usage. Thus, local detention centers are the place to continue or to begin medicated assisted treatment, commonly referred to as MAT. With the passage of House Bill 116, local detention centers are now required to take and provide medicated assisted treatment to all incarcerated inmates. Due to the magnitude of the MAT implementation, a phase-in plan for Maryland was initiated. As of January 2020, the pilot program's jails were Howard County, Montgomery, Prince George's, and St. Mary's. 6 additional counties are slated to begin as of October 1st, 2021, and the remainder to include Baltimore Pretrial Complex by January 1st of 2023. Why medicated assistant in the county jails? Research confirms MAT is superior to abstinence in maintaining freedom from opioid usage after release from incarceration. Mental health, substance abuse, and medicated assisted treatment programs all are keys in successful community corrections and offender reentry services. It has been found with community corrections with intensive supervision as a component combined with rehabilitation services reduces recidivism. The core of community corrections programs are utilization of objective risk and needs assessments, Assessments allow correctional agencies to assign offenders to the programs that will benefit them most, as Secretary Green had already said during the pretrial section. St. Mary's itself, in the use of the community corrections and offender rehabilitation services, has had a profound effect not only on our inmates and offenders, but also their families and our community to reduce recidivism and restore family connections. In St. Mary's County, there are 3 pathways to offender reentry. We have a pretrial supervision or home detention. We have in-house medicated assisted treatment and offender reentry program, or they have an in-house offender reentry. The path to offender reentry from incarceration begins at intake. Our flagship community corrections initiative is the pretrial supervision program, which utilizes a validated risk and needs assessment. The risk part of the assessment instrument assesses to risk to reoffend, and the information is critical to assigning offenders to supervision levels, such as specialized case management, frequent drug testing, and electronic monitoring. The need portion of the assessment instrument identifies the subset will benefit from a rehabilitation treatment program. St. Mary's County's model is being implemented across several jurisdictions in the state, and the program operation is not free, but significantly cheaper to operate than inmates in cell blocks. The path to offender reentry truly begins at intake. St. Mary's is an arrest booking system detention facility, and thus all offenders are brought to the detention center. Before an offender is allowed in the detention center, the offender receives medical and mental health pre-screening. If released by the district court commissioner, all our offenders receive Narcan training at release. If committed to the detention center, the process begins to determine whether an offender will be released from incarceration or will be assigned to a pretrial supervision program based on their risk assessment or remain incarcerated and assigned to a track for offender reentry. It is very much a team effort in St. Mary's County between the custody, medical, mental health, and pretrial supervision staff. We work as a cohesive unit. It is often recommended by, we have the opportunity while we're getting ready for to present for pretrial for bail review. We know that some inmates we are able to observe, and that we can request a mental health competency right at bail review. After bail review, each inmate is assigned a case manager, either for community corrections or offender reentry. If during the medical intake an offender is identified to have an opioid use disorder, then their case management plan includes medicated assisted treatment and comprehensive substance abuse counseling. Pregnant females are immediately placed on the program. Offenders are given the choice of 3 MAT options. St. Mary's County is fortunate to be part of a comparative effectiveness trial of extended naltrexone versus extended release buprenorphine with the Friends Research Institute. Offender reentry case management is challenging at the best of circumstances. However, to assist an offender with reentry housing and or placement in the community program of an inmate with a serious mental illness or who exhibits significant adjustment or behavioral concerns is virtually impossible. These offenders have severed ties with their family and friends. Community programs are already filled to capacity, and getting a bed for someone who has severe mental and behavioral issues is next to impossible, especially with a history of violence or sex offense. The correctional case managers put forth an extraordinary amount of effort and tenacity for placement. In St. Mary's, we are thankful for our community partnerships, especially with the health department, who is instrumental in securing Medicaid for offenders at release to be able to assist with medical and mental health services in the community, as well as substance abuse treatment programs. A robust pretrial system is more than offender monitoring. Both pretrial and offender reentry are systems that serve as a navigator to our many partnerships in the community. These offenders have many complex issues and assistance needed to segue through our systems. To reiterate, housing for homeless offenders or those with serious mental illness are a real challenge. Grant funding is slow to be awarded, and it takes time to implement and hire staff required. Like with medicated assisted treatment mandate, the law took effect in October. However, the grant funding was received in March. For the MAT program, an additional nurse was required to assist with the assessments and medication administration on the weekends, as well as a full-time substance abuse counselor. It is extremely difficult to find qualified healthcare professionals and mental health licensed social workers to work within jail. Staff who work within these walls are basically locked up, as well as their clientele, and it can be less than ideal to work with. Our facility was designed back when the lock them up and throw them away, the key philosophy was commonplace. While grant monies do allow the hiring of the staff, the facilities were just not designed with the office and program space for rehabilitation. Grant monies come with a considerable amount of extra documentation and statistical documentation, which coupled with the actual program work is sometimes overwhelming to get it accomplished. Last but not least, changing long ingrained mindsets is a challenge. On the flip side, what works, and it cannot be overstated, the value and the strong open lines of communication between the judiciary, state's attorney, public defenders, local health department, and the detention center staff, community partnerships and networks for service, and particularly the state mental hospital, comprehensive medical, mental health, and substance abuse contracts, working relationships with allied criminal justice, such as the local police departments, parole and probation, and juvenile justice, and forward-thinking correctional administrators and hardworking officers, mental health and medical health professionals, substance abuse, they form a formidable team. Pretrial and offender reentry work because of dedicated staff who have hustle and heart. In St. Mary's, we are always up for a challenge to improve the lives of offenders in the community we serve. The original facility opened in 1989 and was never designed for the medical, mental health, and behavioral services, nor the amount of substance abuse and life skills required for offender reentry and transitional planning. As with all St. Mary's programs, without the leadership and support of our sheriff, our commissioners, the St. Mary's County Health Officer, and there are many other partners to mention, without leaving someone out, St. Mary's County would not be able to offer the types of services and its expansion of services in years to come. I just wanted to take, and we do have some very good things coming. We got state grant monies. We were in an expansion project. We are in the process of getting a new female housing unit. The female housing unit was not designed, so it will also include a multi-purpose room where we'll be able to do training for the females right off the housing unit, and it will also include a new medical unit. So we're looking at in early 2021 to open up the expansion, and then we'll do additional renovations within the building, which will also free up space for office program offices. COVID-19, it presented a real challenge for us as far as programming. It was just as it was, every square inch of this facility has been converted and repurposed with the goal of rehabilitation. And with COVID-19, you just can't have people in the offices. So we have taken and sent our people to telework. Some are doing telework. We're also working out of the sheriff's office district stations. And however, for a long term, it's, in a service-oriented business such as rehabilitation and community corrections, it doesn't work. However, with the support of the St. Mary's County Health Officer, Dr. Mina Brewster, we were able to procure a 4,930 square foot office modular building, and we'll be able to provide community supervision and our pretrial supervision program out of this community center. The really nice part, it will have room for our community partners such as the St. Mary's County Health Department, Parole and Probation, Social Security Administration, Workforce Development, Parole and Probation, St. Mary's County Library, and so we'll all be able to access out of this community correction center. And for many years, the goal of the St. Mary's County Detention Center has been to further alternatives to incarceration by beginning a day reporting program. The day reporting program is envisioned to be very similar to the pretrial supervision program, where offenders would be electronically monitored, frequent substance abuse tests, and most importantly, a continuum of care from incarceration to the community, with the linkages to the services which would be best to meet the needs of the offender to return them to productive community members. We are working closely with our health officer. For many years, I have been a member and an officer of the Maryland Correctional Administrators Association. While there's still much work to be accomplished, I thought it was important to note the great community corrections work being accomplished by my colleagues throughout the state. In the first couple of months of the pandemic, there was a concerted effort to reduce the incarcerated population. To that end, on May 5th, we did a snapshot of all local detention centers in the state. 13 counties are operating pretrial supervision programs, 14 have home detention programs, and Washington County has a day reporting. Currently, the data for community corrections and day reporting is not being reported on the monthly jail statistics. However, we're working with the executive board is working with Secretary Green's staff to resolve so we can take and collect information in the future so it'll be at our fingertips. Lastly, the bottom line is what we do is for our community. So, and without effective treatment, the alarming rate of opioid or overdose deaths, behavioral health crisis, bloodborne diseases will continue. So we do what we do to make our communities better. And here is my contact information. I knew it was pretty quick and it was a long slideshow, but if you had any questions, I'd be happy to answer.
Okay, we'll come back for more questions. I really appreciate you giving the Division of Parole and Probation some space in the new facility, and I appreciate working with your team. Next, we will have Patricia Towns from Assessment and Placement, Division of Parole and Probation for Baltimore City.
Good afternoon. I am Patricia Towns, Assessment and Placement Supervisor. Today, I will discuss what assessment and placement does and who we serve. Assessment and placement is a clinical unit of parole and probation that evaluates treatment needs for individuals under supervision and on home detention. These individuals may reside in Baltimore City or Baltimore County. The assessment determines whether an individual has a drug problem that requires treatment or if an individual poses a significant risk to the community. The assessment results are used to make referral decisions. Although assessment and placement is a part of parole and probation, we do not supervise clients. Instead, we work together with parole and probation agents and home detention case managers to assist those on supervision to achieve and maintain a clean and sober lifestyle. All of our assessors are certified by the Board of Professional Counselors and Therapists. The assessment tool that we use is the Addiction Severity Index. This tool helps the assessor gather information about the client in multiple areas. The information obtained is used to determine treatment need. Any person currently being supervised by Baltimore City or Baltimore County agent or case manager is eligible to be assessed. This individual supervision status can be probation, parole, mandatory release, or home detention. Often, the individual being assessed has an order from the court that includes a condition requiring substance abuse treatment or evaluation. Persons getting an assessment can get evaluated regardless of their insurance status. If the client is uninsured, after the assessment, the client is connected to the unit's Healthcare Access of Maryland representative. After the assessment is complete, a recommendation is made. There are 12 levels of care available to our clients, and we select the best one suited for their recovery success. Because the unit partners with multiple treatment providers, we are able to provide the client with an appointment at the time of assessment. This means that clients leave most times with a scheduled appointment for treatment. In short, our unit provides a safe place for a person on supervision to receive a substance abuse evaluation where their needs are heard and addressed. Moreover, we assist agents and case managers with questions as they pertain to drug treatment, drug trends, evaluations, as well as any issues with treatment providers. As stated earlier, we partner with approximately 57 treatment providers, but we also partner with 4 other additional agencies. Our partnership with Healthcare Access Maryland includes an on-site representative who helps offenders apply for health care, choose an MCO, or check their current enrollment status. Since October 2017, HCAM has enrolled 1,500 offenders for health care coverage. The Antiviral Linkage Initiative is our partnership with Baltimore Crisis Response. This partnership provides free on-site HIV and hepatitis C testing, results, and referrals to treatment. Since April 2017, BCRI has tested 2,026 offenders for HIV and 1,908 offenders for hepatitis C. As we all know, the opioid epidemic has been especially hard on Baltimore City. The health department partners with assessment and placement by providing offenders with Narcan kits. Our assessors were trained by the health department, and since our partnership began in October of 2018, our unit has trained and distributed about 297 Narcan kits to offenders on home detention and community supervision. Assessment and Placement's partnership with the Behavioral Health Systems Baltimore Certified Peer Recovery Specialist was established in March of 2020. Peer recovery specialists provide a multitude of services that assist offenders with reconnecting with the community in positive ways. In March of 2020, COVID hit the world. Nonetheless, our work at Assessment and Placement did not stop. Since COVID, we have been using telehealth services to evaluate the majority of our clients. 27 of our 52 treatment providers are open and accepting clients. In the rare instance where we have to see a client in person, we use personal protective equipment and safe practices. I'll leave you guys with this thought. Assessment is the engine which drives effective recovery. I thank you for your time.
Thank you, Ms. Towns. Are there any questions for the panelists? I want to thank everyone on the panel, and I'd like to circle back to what Jen Corbin said, and it fits everybody at this summit, is the culture to help. We're all a part of that culture. With that, I will turn it over to the Executive Director, Steve Shue, for closing remarks and next steps.
Thank you, Martha. Can you hear me okay?
Yes, we can hear you.
You did a wonderful job emceeing this terrific event. It's been very, very interesting, and I want to thank all of you for attending today's Sequential Intercept Model Summit. I'd like to begin by thanking Lieutenant Governor Boyd Rutherford, Senator Katie Fry Hester, and Dr. Linda Benesky for their leadership in addressing mental and behavioral health here in Maryland. Additionally, we're grateful for the participation and support of Senator Will Smith, Secretary Robert Green, Chief Judge Morrissey, and Director Martha Danner, who did such a nice job. We were fortunate to have quite a series of panelists today. A lot of rich, powerful material was shared this morning, and I think one of the biggest takeaways from today's presentations is that the prevalence of serious mental illness, or SMI, is 4% in the general population, but 17% in jails. And of the 17% of people who are incarcerated with SMI, 72% have a co-occurring disorder, and 56% have a diagnosed substance use disorder. We also learned that individuals with SMI are very likely to have experienced trauma, including physical and sexual abuse. Addressing trauma and preventing further trauma is a key element of our work. Today's presenters have provided us with a lot of background on the programs that they are running in our communities, programs that do so much to improve the overall behavioral health picture here in the state and to make our own contributions to the prevention of trauma. LaWanda Williams told us about healthcare for the homeless, which serves individuals who are justice involved, are more likely to have health conditions, and are at higher risk of overdose. Lucy Bill from Washington County's LEAD program explained how their robust program focuses on the root causes of low-level offenses. Washington County's LEAD program was just introduced a little over a year ago. It's the new kid on the block, and we welcome that program to the state. Lieutenant Governor Boyd Rutherford was with us this morning and announced 2 more LEAD programs that are being launched in Carroll and Harford counties. Wonderful developments. LEAD programs are very important tools for empowering law enforcement officers to refer individuals who may have a substance use problem to public health services instead of making an arrest. These programs reduce costs related to the criminal justice system, which was a major goal and is a major goal of the Justice Reinvestment Act. We also heard from Jen Corbin and Lieutenant Thomas, my old colleagues from Anne Arundel County. In Anne Arundel County, police and mental health clinicians are working together to help those in crisis through a model crisis intervention team program. The Anne Arundel County Police Department plays a big role in this system. It's critical to its success through its forward-thinking efforts to train its officers in mental health first aid and trauma-informed care. The system is also successful because of the follow-up that is an integral part of its design. Today, we also learned that there are a lot of concepts that are consistent across all of those intercepts. Those intercepts each represent an opportunity to intervene for the betterment of the person and for the betterment of our community. Those consistent concepts include healthcare reform, information sharing, trauma-informed approaches and trauma-specific treatment, cross-system screening for special populations, integration of peer services, housing, and of course, access to medication-assisted treatment, MAT, something that we truly believe in here at the OCC. I think it's fair to say that we've all taken a lot of new ideas from today's sessions, and I'm excited to see how these will inform everyone's work in the state. Several of us will be back again tomorrow for day 2 of the conference, where we will be getting into the weeds on how to address each of the intercepts discussed statewide. We certainly look forward to seeing everyone online at that time. Thank you again, and thank you for having me.
Okay. Thank you, Steve. Let me just add to your comments, although they may overlap a little bit. I think the first thing that impressed me as I was listening to all the panelists is that if I just closed my eyes, I couldn't tell who the social workers were and who the justice professionals were. I mean, if you were a conductor, you'd have everybody. I mean, it would be everybody's playing on key and playing the same tune. Again, Rolanda Williams asked, we need to increase the pool of landlords. It's Judge Taylor talked early on about data. It's also housing. There has been discussion in the panels about the failure to appear problem that comes up and how challenging that is. When we've looked at failure to appear issues in other communities, an overwhelming number of the failure to appear individuals are homeless. And they're compromised because of their health status, and so they don't make their court appearances. Then the warrant comes, and they go back to jail. They get released without resources, and that cycle continues. So homelessness is a huge driver of low-level offenses and repeated incarcerations, and it's as challenging an issue as for states as it's ever been. I think there's more and more headlines about about how communities are criminalizing homelessness. It's an issue, frankly, that will take some courage, I think, for the states and the federal government to address. I don't think it's going to be just a state issue. I think the federal government at some point is going to have to step in. I liked, and all the panelists talked about the importance of partnerships, and they all enjoyed, very, very robust partnerships, and can also serve these programs can serve as learning sites for other communities in Maryland, I think. I liked Jen Corbin and Lieutenant Arnold's emphasis on the peer support culture of helping and developing a peer support program. Too often the wellness needs of law enforcement and correction officers too, I don't want to exclude them, are overlooked. And I just came across a study this week that of a program in Texas. 12% of the officers surveyed had a lifetime mental health diagnosis, but only 35% were currently getting any treatment. 26% endorsed having psychiatric mental health symptoms. And again, only 17% sought help. There's a lot of reasons why that is. And it's a challenge for police officers sometimes and correction officers, one, to admit that they need help. Number two, to recognize it, that they might need help. And they need, and peer support is one of the strongest strategies to begin to work with law enforcement and correction officers. So again, I encourage that kind of approach in other communities and other jurisdictions. And I like Judge Lippman speaking. I mean, talking about holistic justice. I mean, we talk about holistic care in the health circles all the time, integrated services. But for a judge to be out leading really, it could be a new catchphrase. Let's look at holistic justice. Again, across these program models that we saw, there are, we talked earlier on about healthcare integration, and there were a lot of examples of healthcare integration that were presented among the panels with co-located services and in-reach services. Scott, I liked what you were doing in the Howard County Jail with the in-reach services and encouraging folks there to accept their medication-assisted treatment, and then that very, very important transition piece back into the community. So I think one of the things I really like about the summits is hearing the panels and letting the panelists in the communities really get a chance to brag, your day-to-day, programs that you're working in and developing. It's hard work. And I think it's a good lesson to be able to, and a good practice to be able to step back from all that hard work and really appreciate yourselves and share what you're doing with the communities. And I think that was very effectively done today. I want to ask Dr. Pinels if she has any other additional comments and observations before we end the morning summit.
Well, I know we're getting close to the ending, so I'm just going to keep my remarks to just a few. I think what's really exciting seeing all these presenters is that there is something to talk about. Maryland is not a state that's done nothing in this space. And so I really loved what we heard about the law enforcement mental health partnership that's growing and thinking about those responses, the peer support work that's being built upon, the work with the courts and the jails. So I think there's a lot of opportunities to grow from. And then the question is, what are the gaps that are still there? Are the services, are these strategies available statewide? These are things that you might want to think about for tomorrow. Are they available statewide, or are there pockets of success? And if there's pockets of success, how do those get expanded? As I've worked again at the local and at the state level, that's one of the biggest challenges is what are the things that you can scale so that everyone in the state has access to the innovation or the innovative approach? And what are the things that, still require that local involvement? So I think those would be things for you to think about as we get into the workshops for tomorrow. But it's really, you're starting from a great place, and you can only go forward and up from here.
So there's been a number of questions in the chat about tomorrow and why some people were invited and some weren't. And I just want to deal with that transparently. When we've done these summits, there's kind of a sweet spot of the number of people when we do this during the strategic planning piece in terms of the numbers of people where we can feel we can have a productive conversation. And we capped it somewhere around 75. Otherwise, we can't get deep enough into the conversations that we want to have in order to have an effective event. And which isn't to say that as you know, the Maryland Commission to Study Mental and Behavioral Health won't have other opportunities. There will be some follow-up to the summit. We'll be issuing a report. There'll be some action steps, frankly, that will come out of this summit. And there may be opportunities then to participate in this discussion moving forward. But I did want to be transparent about why there was a smaller group. It was how we designed this summit in terms of having larger participation in the morning for the question and answers and the presentations, but a smaller group to have a more intense discussion with. So I hope that satisfies some of your inquiry about that. But I do also feel that there will be opportunities moving on to be more involved in what the outcomes will be from the summit. Senator Hester?
I think that was really well said. And I'd just like to thank everybody again for their time and attention today. Lots of great ideas, lots of great things going on, and of course, a strategic road ahead to continue to improve what we're doing here in Maryland. So I will see many of you tomorrow morning to tune in. And I'd just like to remind everyone that I tried to tweet lots of the slides today, lots of the great remarks made by people. So you can follow me on Twitter. And then if you want to share the entire experience with folks, go to Lieutenant Governor's YouTube channel where the whole thing is recorded forever and ever. And on that, I hope everybody has a great lunch and stay healthy. And thank you again very much.
Thank you.